Welcome, everyone. Thank you for being here today at our annual conference and for each of your contributions to our shared mission of improving behavioral health and substance use treatment in Massachusetts and beyond. My name is Corey Cather. I'm a clinical psychologist at Massachusetts General Hospital in the Psychosis Clinical and Research Program, and I am the director of the MGH Center of Excellence for Psychosocial and Systemic Research. Dr. Marianne Davis and colleagues from our sister center, the Implementation Science and Practice Advances Research Center, or iSPARC, at the University of Massachusetts are co-hosting today's conference. I want to thank the Department of Mental Health for funding our work and to give special thanks in particular to Dr. Kathy Sanders and Dr. Margaret Geyer. They serve an incredibly important role as the DMH touchstones for both of our centers, and we are extremely grateful for their dedication and support, as well as the intellectual contributions they make which shape our projects and initiatives. I also want to thank our colleagues who will be presenting today, our wonderful team of American Sign Language interpreters, Kathy Hammerstrom at DMH, who provided invaluable assistance with securing continuing education credits for attendees from a wide range of disciplines, and our colleagues at the MGH Psychiatry Academy, who are providing technical assistance with today's virtual program. I think we have a great program for you today. The content is organized around the theme of the efforts of the Massachusetts Department of Mental Health and the centers to support youth, young adults, and families with mental health concerns. Before we get started, a few small housekeeping items. So just to pay attention maybe first to the emails here, you might want to write these down. If you have technical issues during the conference, you may email either Liz McShane or Leslie Tanaka at these emails here. If you have questions after the conference, please email either of our centers, MGH Center for Excellence and iSPARC at UMass. Their emails are here or their websites are easy to find. Your microphones are muted. Please do keep your microphones muted throughout the conference. Please use Q&A for the questions. As I mentioned, we are interpreting the entire conference in ASL, and closed captioning is also available to anyone who would like to use it. In order to access the closed captioning, you should see a CC indicator at the bottom of your Zoom bar, which you may click, and this may be clicked on and off. At times, you will be seeing video that is already subtitled. During those times, you don't want to have your closed captioning on because it will interfere. We are recording this conference and it will be available on our center websites. A few quick words about CEUs. Please take note of this email address here, co@staffdev@massmail.state.ma.us. That is the email that you would want to email if you have any questions or concerns about CEUs. It is absolutely essential if you're getting CEUs that you complete the evaluation following the conference. In addition, we really want to have as many people give us feedback on the conference as possible. This is an annual conference. We really believe in stakeholder input, and we use stakeholder input to shape our agenda. So please do fill out the survey at the end of the conference. We've done a couple of things to try to make it easy. We will be ending this conference today at 4:20, at which time you will immediately receive a pop-up with a connection to the survey. Please take that moment, if you would, to complete the survey. It should take 3 minutes, and it is incredibly valuable to us. Of course, there are other guidelines you have to follow if you're going to be collecting CEUs. Without further ado, I would now like to introduce our first speaker, Commissioner of Mental Health for the Department of Mental Health, Brooke Doyle, who will be providing our opening remarks. And Brooke Doyle was appointed Commissioner for the Department of Mental Health in October 2020. Not a very easy time to come in as Commissioner. She has a wealth of clinical and management experience. She's a long-term champion for mental health parity and for improving mental health access. She's a licensed mental health counselor, an alumna of the University of Massachusetts, where she received both her MED in rehabilitation counseling and her BA in psychology. She has a wealth of experience in the fields of homelessness and substance use disorders treatment, both of which are critical issues to attend to as we strive to reduce barriers to access. Prior to being appointed the commissioner, she served as the deputy commissioner for mental health services, and in that role, she oversaw DMH's adult service delivery program, led interagency planning and projects, and provided administrative and clinical leadership for all aspects of DMH statewide service compliance monitoring. It is with great pleasure that we have Brooke Doyle here today to introduce our conference and to kick us off. Thank you.
Thank you, Corey. I appreciate the opportunity to join all of you, and welcome to the Department of Mental Health's annual Centers of Excellence Research Conference. This conference creates an opportunity to hear about the important research being done in Massachusetts to potentially improve lives of people experiencing mental illness. It's a unique complement of researchers, people with lived experience, and the families that support them, creating collaboration that we can all benefit from. The work of the Centers for Excellence reflects the mission of DMH and the promise of the Behavioral Health Roadmap. The centers and the roadmap work to be inclusive and responsive in all communities, and they have a goal of reflecting the diversity of our state in both research and treatment. The Department of Mental Health consistently stresses the importance of reaching people as soon as possible in their mental health journeys. And that echoes the importance of the theme of this conference. How are we supporting our youth, and how are we supporting their families? So many young people and their families seek support through hospital emergency departments. And one of today's speakers, DMH's own Dr. Kathy Sanders, has worked tirelessly throughout the pandemic and before to ensure that their stay in the ER is as short as possible. In conjunction with the efforts to find psychiatric placements as soon as possible, DMH has also supported an ED diversion approach, which assesses whether a young person can receive intensive support in the community and then sets up the in-home care when it's appropriate while the person is in the ED, and that diversion team can stay with the youth and their family until they're stabilized. This model has served the dual purposes of relieving pressure on emergency departments and creating a faster path to treatment that keeps the young person at home with family. We are excited to hear from all of our speakers today, Dr. Sanders and Drs. Daphne Holt and Ren Whitman of Mass General, and Dr. Kathryn Sabella of UMass Chan Medical School, as they lead the discussion of the ways that we can support our youth and families further. Thank you for being here today, and I hope you enjoyed today's conference. I appreciate the opportunity to open this conference experience. Take care.
Thank you, Commissioner Doyle. Hi, I'm Marianne Davis. I'm the director of iSPARC, and I have the great pleasure today to introduce our next speaker, as Commissioner Doyle referred to her as our own Dr. Kathy Sanders. She serves as the Massachusetts Department of Mental Health's Deputy Commissioner for Clinical and Professional Services and is the State Medical Director. She oversees the department's development and implementation of clinical standards in a statewide continuum of care for people with severe and persistent mental illness, as well as overseeing DMH training grants, the Research Centers of Excellence, policy development, licensing, quality and utilization, and collaboration with other state agencies. She's very busy. Previously, Dr. Sanders was the director of psychiatric residency training program for the Massachusetts General and McLean hospitals. She's also served as director of the acute psychiatry service in the emergency department, also referred to as ED. Her academic focus included medical psychiatry, the management of aggression and violence, training, and physician leadership. She maintains her clinical and teaching appointment with the Mass General Department of Psychiatry and Harvard Medical School. Dr. Sanders graduated from the University of Pennsylvania with a bachelor's degree in, interestingly, biochemistry and women's studies. Her medical degree is from the Medical College of Pennsylvania. She did a medical internship at the U.S. Public Health Service Hospital on Staten Island, and she came to Boston for a psychosomatic medicine fellowship at Mass General Hospital 30 years ago. I've had the pleasure of working with Dr. Sanders since 2015 in my role as the director of iSPARC. And I'd also just like to add that she brings great intelligence, thoughtfulness, passion, and compassion to her work. Kathy.
What I would like to talk about today is really how the COVID pandemic has impacted the individuals that we serve, particularly youth, and how presenting in the emergency department for behavioral health issues has really expanded in ways that none of us fully anticipated, but ultimately we understand that this would be the direction. I also wanted to get involved a little bit with more data of the real life, in the moment data and experience that we're currently having in Massachusetts. I wanted to acknowledge that there's various surveys throughout Massachusetts, and the Health Policy Commission has collected and analyzed some data, but none of it really expresses the immediacy of what we're experiencing day to day. And part of that is Health Policy Commission data is claims data from insurance billing, and it actually takes about a year to 2 years to be comprehensive and complete. So when I was studying some of that data, it wasn't quite reflecting what we experience day to day here in Massachusetts in behavioral crisis in EDs. And to really finalize my presentation, I want to talk about what the Massachusetts response has been to the COVID behavioral health crisis, and particularly highlight what Commissioner Doyle mentioned, the behavioral health roadmap, which is really designed to become an equitable, accessible, true system of accessing treatment in a true behavioral health care delivery system. So the impact on youth has really been based on the isolation from peers and disruption of psychosocial development, decreased activity, but increased virtual engagement in other things that have really exploded with social media, gaming, and surfing the internet. Also, the concern is increased time spent with dysfunctional family environments that could be due to the stress of unemployment, crowded living conditions, and or just a host of issues with where family are working, if there's been job loss, fear of disease in the family or in oneself, the loss of structure, financial insecurity, all of that ultimately results in increased anxiety, depression, a worsening of underlying behavioral conditions and disrupted development. And we see that through almost through the whole span of the lifespan. And okay, so thank you. So you took over control. Okay, so what has happened is that with all of this increase of anxiety, depression, and acting out behavior of all kinds to express the distress, including increased self-injurious behavior and suicidal behavior, more visits are coming into the ED because there's limited in-person treatment options, and there's not as adequate usual care approaches that may not be as accessible and may not be as effective, maybe because of their being virtual. So next slide. So what happened is everyone noted that in March, when we sort of closed schools, closed the social environment, employment, ED visits of all kinds plummeted. And behavioral health visits make up about 10% of the behavioral of visits in ED in emergency departments. And they never went down as low as the medical visits, and they started coming up sooner. What we found is by June of 2020, 3 times the number of behavioral health visits were in the emergency department as compared to June of 2019. Mass Health started seeing this in their stats. And what we have all noted in all of our work with EDs is there's been a persistent 250 to 400% increase of behavioral health visits in EDs throughout 2020 versus the same month of 2019. What we also noted is that this is not time limited. In fact, as the surges have been becoming less impactful and more of normal life is coming back, the behavioral health visits in the emergency departments are not going down. In fact, as you go through 2021 and even 2022, there is a slight increase of those behavioral health visits in the ED. And the challenge with this is that behavioral health visits are actually longer, and there is a more difficulty finding placements. And the pandemic conditions really affected inpatient and residential programs. First of all, keeping them open was the biggest challenge, and then keeping them at full capacity. So what we ended up having is quite a clogged system, going back into residential, flowing through the ED, getting back home with in-home supports. The workforce was markedly decreasing in response to COVID, some due to the infection and some due to workforce challenges. Next slide. So what we learned is in the pandemic, ED borders increased, the length of time in the ED definitely increased, especially for youth. And anecdotally, the acuity and the complexity of those presenting to the EDs were much higher, and the demand for inpatient service increased because of that acuity and complexity. But beds were blocked due to workforce shortages and COVID infection, as I was just describing. The total number of licensed acute beds in Massachusetts is roughly 2,900, and about 400 of those are for child and adolescents. During the surge or during COVID, we've not been able to open more than 2,500 of those beds, so that you see this automatic loss of 400 beds capacity to serve the population. Similarly, the community resources, community-based acute treatment for children and adolescents, and group homes all had similar problems with decreases in workforce and closures due to infection. Next slide. So what I'm using is some of the expedited psychiatric inpatient admission programs data. This is real time, where individuals boarding in EDs have an escalation process so that individuals are not boarding for long periods of time without either insurers that insure them or state agencies are not aware that they're there. And during COVID, we decreased from 96 hours, which is 4 days of boarding before you could escalate to the DMH level to get our attention. Or we went down initially to 24 hours and then back up to 48, just to try to clear EDs at the height of the biggest surge at the beginning. But ultimately, toward the end of 2020, we stabilized our escalation to 60 hours, 2.5 days, which gives adequate time to both the emergency department, the emergency service teams, and insurance companies, adequate time to really work on opening up beds, bed searching before they ask for DMH help to continue finding beds or helping with placement. And so what I'm showing you here is the month of December. The first bar is the month of December 2020, but it really spans through the whole year of 2021. And the data I'm going to review is data of calendar year 2021 and what we learned. And I sort of put this up because the red bar, or the red part of the bar, are the number of youth. And really, if you look at sort of June, July, and August, the lowest proportion of youth is noted, where it's 18%, 22%, and 38% was the most during June. But in July and August, it decreased to 18 to 22% of all of those boarding. And you can see the incredible numbers that were boarding longer than 60 hours throughout the Commonwealth. And this does not include people that have developmental disabilities and require a developmental disability unit only, because there's only one unit for youth and there's only one unit for adults. So our efforts cannot be really spread out the way we'd like to work to find an opening bed. So you can see that throughout 2021, there was a strong surge of behavioral health visits in EDs around March, the spring, where children actually during March were 48% of those referred to us. And another surge in September, October, when youth are going back to school, 39%. But in November and December, it was really like around 40%. And you can see that there was another expansion. Next slide. Additionally, this starts from March 2020 and goes all the way to the end of December 21. And what it shows you is the change in hours of escalation to the DMH EPIA program to help individuals boarding get a bed when everything is not moving quick enough. And what you'll see, this is a trend line. The trend line is absolutely going up. It went up through 2020 and it has continued going up through 2021. And just to give you a little snapshot of 2022, in January, we had 920 referrals, an all-time high for this program. Next slide. What I wanted to show is the complexity here. In the last 10 years, the total admissions to inpatient psychiatric units of all kinds averaged about 70,000 per year. And what you see in 2020 and 2021, the number of admissions were significantly decreased. And yet the demand for admissions were higher than ever. And that was part of what caused the boarding. Please, next slide. So I wanted to now review quickly what we learned in calendar year 2020. And what we learned is that in that year alone, DMH saw 7,331 referrals to assist in inpatient placement from EDs. This was up almost twice as much as we had seen in calendar year 2020, when we were even taking referrals at 24 hours part of that year, only 4,000 some. In 2021, 36% youth, 64% adult. And what we found is 14% of the referrals in that year had more than one visit, long visit, more than 60 hours to an ED during 2021. 26% of the population referred were state agency involved, and most of those were DCF, Children, Youth, and Families Division, and DMH, Department of Mental Health. what was significant is that many of these people escalated to DMH help. 40% had a level of care change. That meant they did not go inpatient. They went home, back to their residence, or back to another less restrictive level of care. But even more importantly, it had a difference between youth and adults. And we found that the youth statistics and the adult statistics in this program are very different. Almost half of all the youth that came to EDs for inpatient level of care, and before they left, they actually did not go inpatient, but went to a different level of care or were discharged home. Only 37% of adults. And the people so ultimately we only admitted 4,000, almost 400, which reflected 7% of all the admissions of 2021. And about 73% of these long waiting ED boarders that required DMH help to get placed were admitted to only 30% of the licensed inpatient units that we have. Next slide. So what I wanted to do is look at a referral trend. On the right-hand side, it's the 2019 stats before COVID, when we saw long boarders starting at 96 hours or 4 days boarding. Then 2020 and 2021. And you can see just by time alone changing to 60 hours, the numbers just really ballooned. And it's significant, very significant, that 2.5 day boarders in our Commonwealth were more than 7,000. And given that there were many developmentally disabled people waiting, and as well as medically ill patients in medical beds in hospitals that were getting medical treatment and then also required a psych bed, were not included in these statistics. So you can imagine there might have been much closer to 10,000 people in a boarding capacity in our system. The average wait time to placement, ATP, we did not have the statistics for 2019, but in 2020, it was 2.5 days after they were escalated to DMH. But it took a whole longer day on average in 2021 to place individuals. And you can see that change of level of care was only 14% in 2019, 29% in 2020, and up to 40%. And part of that was because of the immense boarding that was going on through 20 and 21, and that this resulted in not going inpatient for those that might have started an ED visit, but got treatment, stabilized, and were able to either go home, back to their residence, as I said before. And I just reflected the change in admissions and the amount of admissions that the EPIA, the DMH escalation team, actually contributed to the total number of admissions. 1% during 2019, 5% in 2020, and 7% in 2021. Next slide. So this is aggregated data, but slightly, it's aggregated only for the youth. The youth during 2021 numbered 2,670. And what you can see that if you divide the ages to latency age versus adolescence, it took on average 6 some days to place a child waiting in an ED. That's tacked on to 2.5 days that they already waited before coming to our attention. And adolescents were closer to almost 5 days. And the average day number to placement for all youth under 18 was 5.2 days. And you can see that females dominate in the youth, 56% women, 38% men, and 7% transgender. Race and ethnicity, I just wanted to put on the far right column that you're looking at. These are the Massachusetts population as determined by youth registered in Boston public schools or Massachusetts public schools. This is Massachusetts total population in schools divided by race and ethnicity. And what you can see that for the EPIA youth, 46% white, which is down from the mass population, 14% Black, which is up from mass population, 16% Hispanic, which is down some, less than what is expected in mass population, and Asian is down some from expected in population. Next slide. This is just a quick comparison to the adult, which for 18 and above, 4,600 some. And what I wanted to highlight was the average time to placement for adults was 2.5 days. So you can see, in general, it took twice the amount of time to place youth. And we'll get more into that a little bit. And similar stats in reference to race, ethnicity. Okay. Let's talk about what we've done. So during the policy and regulatory changes that we made to respond to this increased presence of youth and adults in EDs in behavioral health crisis, it has to be a multi-causation solution. So the behavioral health roadmap is the way forward, because a very prominent component of this is a 24/7 helpline that actually triages and sends individuals to immediate access to treatment. There are going to be community-based crisis services that are going to be an alternative to ED help, and the community behavioral health centers, which have just been both the helpline and the community-based behavioral health centers are also just being procured to have immediate access to treat people as they need it at the right time and the right place. That's the whole premise of the behavioral health roadmap. And during the pandemic, regulations were adjusted so that telemedicine was readily and easily used during concern of exposure in the medical delivery scene. And there was an expansion of the scope of practice for some licensed staff, such as nurse practitioners, which became a law, so that nurse practitioners are more independent and have a larger scope of practice, similar to psychiatrists. And also physician assistants have also had an increased scope of practice, but just during the COVID emergency. Additionally, DMH, under the needs of the Commonwealth, prioritized building or increasing beds for children and adolescents and other specialty units. And as we continue at the EHS level, Health and Human Services Secretariat, we monitor ED for volume and acuity and target interventions for some of those EDs as their need requires. Can you forward to slide 20? The financial and service changes that the state responded with was that there was funding and regulation support to increase inpatient bed capacity and also to ensure clinical competencies at the same time. So $20-some million were spent to increase beds throughout the Commonwealth with a focus on child and adolescent beds. Additionally, there were multiple rounds of both federal and state COVID funds that were distributed to all psych hospitals and community behavioral health providers to support the continuity of operations. And there were several COVID units opened up in psychiatric hospitals that were funded by Mass Health so that there would be access during the surges, so that people that were COVID positive and mild symptoms were able to be in psych units and get acute psych care if that's what they needed. Additionally, Mass Health has enhanced their rates and increased the rates to hospitals per diem to account for the increased costs for COVID infection control requirements. And the increased incentives for increasing bed numbers over the 2019 capacity. And you can see from 2019, almost 2,900 beds, we've increased the capacity up to 2,900, but the difference between operational capacity and licensed capacity grew every single year through the pandemic. Additionally, ED diversion programs, first by DMH and then for Mass Health, have been built up. The final slide, slide 21. So ongoing planning initiatives, we're continuing to have incentive funds to increase bed throughout this year 2022. The ED diversion initiatives are strong. DMH is involved in 39 different EDs across the Commonwealth, where they have either youth and or adult diversion teams that have a sort of, they come in, they assess for the ability to divert and have in-home care in a warm handoff manner that is regular daily contact until they've been connected to the outpatient provider, until they've established a partial hospital program, whatever the diversion treatment is. There is a very comprehensive and warm handoff process. DMH is also funding PACT teams for adolescents. This is a first. And part of the behavioral health roadmap will include adolescent respite beds as well, to give a respite for both the adolescent and the family rather than using the ED for that possibility. MBHP, which is one of Mass Health's biggest providers of behavioral health services, will go live in July with an ED diversion initiative of their own for the Mass Health individuals. The DMH ED diversion team is all payers, and no one gets paid, no one has to get a bill. The ED diversion teams from DMH are not billed, and they will serve anyone of any insurance provider. So I wanted to just let everyone know, and I said it before, that the roadmap is out there, it's being procured, and all of this will be going live by January 2023. The insurance carrier transparency and billing codes have increased money paid to EDs as well as inpatient care systems for required specialing, one-to-ones, single room rates, and increased acuity of medical complexity per diem get raised. And this is all worked out while in the ED. Additionally, Mass Health is preparing behavioral health assessment and treatment billing codes while people are in the ED. So when there are treatments being developed and delivered during an ED visit that can last days to weeks, that there will be billing options daily. The ARPA funds that are part of the COVID rebuilding funds from the federal government are going to help us build a technological solution to support electronic clinical information transfer between EDs, inpatient units, ESPs, and state agencies. And also there's a host of workforce issues that are also being addressed by these ARPA funds. And I think my final slide, which I will hold up with questions, is sort of summing what I talked about. Behavioral health visits in the EDs have increased threefold since pre-COVID and are continuing. The ED boarding issues are not really unique or different, they're only magnified. And the public insured youth and adults are overrepresented in the long waiting ED boarders. And the state response really revolves around a behavioral healthcare system reform, the behavioral healthcare roadmap. So thank you for your attention. I know I was a whirlwind, but I would entertain a couple questions as there is time.
Thank you so much, Kathy, and thank you for your grace in the face of several technical changes, which are never easy to.
I'm so sorry about that.
No, that was you handled it very, very well. We got through all of the slides, and we have a couple of questions that people have posed. So the first question is really in regards to sort of when a child arrives in the emergency department and the goal may be to have that change in level of care to going home. The overall question is sort of how is the environment considered if there may be some concerns about that not being appropriate, either for issues because of domestic violence or some other consideration. So kind of an overarching question about how is that taken into consideration in trying to ensure that a child gets appropriate care.
When there's aggression or violence or even assault in the family, and that is not resolved during the course of a time in the ED, even if there's been some treatment going on in the ED, most EDs do not deliver treatment while people are waiting. And it's an incredible shame because most EDs don't have windows and you're in a windowless box for days. But if there is that kind of violence, aggression that's not been resolved or worked through with family therapy, those individuals are likely going to continue waiting for an inpatient bed. That's part of it. That complexity really requires continued inpatient placement. However, if there is a resolution of the immediate difficulty with violence or aggression, it was really an explosive, dysfunctional response, and either behavioral techniques were trained or used during the ED wait, and an in-home team can go with the family and meet either daily or several times a week to ensure safety and continued learning and using skills for the safety and the continued treatment of the youth. Then that will be what that kind of decision and assessment is what happens.
Great, thank you. Our second question is, how many more beds will be added for children or adolescents in 2022?
There have been about 150 to 200 beds added to our current system, but the problem right now is most of those units are not fully operational because of the lack of staff. So when we open up new child and adolescent units throughout the Commonwealth, they usually start with a couple beds and they generally ramp up to about half the unit's capacity because staff are not hireable right now. So that's why we're not at our capacity. But there are going to be more beds coming online through the course of this year and probably into next year. But everything is going to depend upon the workforce coming back more robustly to manage and give what we need to help our youth.
Great. Now, we have all kinds of questions popping up now. So from another individual, apologies, they came in from another meeting, so I may have missed this, but are any ARPA funds purposed for youth enrichment or engagement programs, specifically BPS, as opportunities for intervention or screening?
So ARPA funds have been distributed to the legislature, I think almost 400 million. They've been distributed in varying amounts to Mass Health, which also has a nice big chunk, and in smaller chunks to all the state agencies, DPH, DMH, DCF, DDS. And all of these different piles of money are actively being procured in very creative programming. So some of what DMH is doing, and they range the gamut from some of what you talked about, enrichment, support, all of that, flexible funds that are known in DMH. Those are being enhanced and developed. So I don't have a list of all the different programs because actually a lot of it is in procurement and in think tank level. And I highly encourage you to influence state legislators because they have a big pot of money and they are in a process of figuring out how to spend it. A lot of it's going to workforce initiatives.
Okay, our next question is, thank you for a wonderful and informative presentation. Would you tell us more about the Youth Village Intercept model with warm handoff? Will you be utilizing young adult peer mentors for teens?
Well, DMH has a real strong use of peer mentors, and peer mentors are part of these diversion teams. And again, based on staffing and workforce, most of the teams can be fully staffed because that's where a lot of our focus is going. So we're really building out these teams. They do include peer, and they do include peer engagement in the ED when the team is going into the ED to try to engage the youth or the family, and there's teams for adults to engage to a problem solving and resource enhancing way to make it feasible for someone to go home or back to their residence with extra services. And that team, that is the ED diversion team, is responsible for personally managing the warm handoff, both through calls, visits, follow-up.
Great. And I see we are actually over time. There are three
Sorry
more
about
questions that I think, no need to apologize. I think what we'll do is save these questions and we'll shoot them to you after the presentations are over, so you can.
Well, thank you very much. It was a delight to be with everybody. Continue to have a good conference together.
Thanks, Kathy. Dr. Sanders.
It is now my pleasure to introduce my colleague, Dr. Daphne Holt. Dr. Holt is the director of the Resilience and Prevention Program in Emotion and Social Neuroscience Laboratory. She's an associate professor at Harvard Medical School, and she essentially really looks at the neural basis of emotional functioning and social behavior. And she tries to understand these in order to develop new treatments that can help people with clinical disorders like schizophrenia. The part of her work that she's going to present on today is really exciting and cutting edge, in which she takes a transdiagnostic approach. So sort of forgetting about the boxes that we put people in terms of diagnoses, and thinking who looks like they might be vulnerable to experiencing mental health challenges down the road, and thinking about some of the ways to offset some of the problems we see later on in people by catching it early. This is a model that obviously transcends all other aspects of medicine. We have not done a really good job of this in psychiatry. I can't say enough about Dr. Holt's career. She has been continuously funded by grants for a very long time, has published extensively in very high impact journals. She also co-directs the schizophrenia or psychosis program now, as it's called, at Massachusetts General Hospital. She's a wonderful person to work with and has built an incredible team. And we're so proud to have her as one of our colleagues. So I'll turn it over now to Dr. Holt.
Well, thank you so much, Corey, for that very, very kind and generous introduction. It's so nice to be here today. I really appreciate the invitation to speak. And this is a great sort of sequence of talks too, because Dr. Sanders' talk is a perfect segue to mine. And it was great to hear that very compelling, although obviously, disheartening in some cases, data about what's happening in terms of the effects of COVID on our systems of care and post-COVID. So, okay, does everyone see that? Okay, good. All right. So, I won't belabor this because actually, Dr. Sanders' talk really fleshed this out in real numbers, but as you all just heard, and you see constantly probably in the media and the newspapers and magazines, that the pandemic has really affected young people in terms of their mental health disproportionately. A lot of people obviously been struggling during the pandemic, but young people have been particularly affected psychologically by the pandemic. And there's been lots of different kinds of studies showing this, and I'll just show you a few examples. Well, here are some headlines, just to kind of, some of these headlines you might even recognize because some of them are very, like the top one is from last weekend. There was actually a story today in the New York Times that was about exactly what Kathy was talking about. So yes, there's even early on in the pandemic, so this is data from the CDC from the summer of 2020, it was very clear that if you see the way this is graphed, the dark orange represents people who are sort of 18 to 24, around the time that some people are in college. And you can see that they have the highest rates of 75% of people in that age group in this large survey said that they were struggling, they were having some symptoms of a mental health condition. And 25% actually expressed that they were considering suicide in the past month, which is more than doubling the typical rate. This is just another graph, another survey, a different survey. And if you just focus on this blue line, which again focuses on this age group, 18 to 24, you can see from 2019 to 2020 to 2021, there's been this decrease in mental well-being. And then this is a graph from the same study that basically plots it the opposite way. So if you look at this blue line again, this is a mental well-being zone of distressed or struggling during the pandemic. So 2019 to 2020 to 2021, that these percentages are extremely high. And then similar surveys conducted in adolescents show some similar data. We heard just in the last talk a lot about why this may be, but this is something that is persisting even as the pandemic. It doesn't seem to be completely tied to lockdowns or school closures or that sort of thing. So I think that it's still a little bit. It's not entirely clear, what the causes of this are, but it's definitely a problem that's persisting. And here you can see that there's some differences across ethnicities, and that youth with parents born outside the US have been particularly affected, which we'll talk about a little bit in a minute, a little bit more. But as Dr. Sanders also alluded to, the mental health of young people was worsening before the pandemic. This has just been a trend of the past, several decades. So you can see the percentage of high school students considering suicide has been ticking up since 2009. So that if you sort of look at the overall increase, it's quite large. And this is all pre-pandemic data. And then really, it's not just youth. I mean, the mental health related visits, the emergency rooms, which we just heard about, have been increasing steadily. Deaths by suicide, mental health conditions were the largest cause of disability in 2019. And then there's this huge gap in care, that there's a huge group of people who are not receiving any treatment or any kind of attention. So the main sort of thing I'm going to focus on here is, what can we do? What can we try to do to reverse this trend? And obviously, I'm not going to answer that question fully today, but and there are lots of different ideas out there, most of which I won't be touching upon, but I'm just going to sort of talk about a few ideas and a few things that we've been doing to try and address this problem from a sort of prevention perspective. So I think in some ways I'm going to start with kind of what could be sort of the end of the talk, but I just want to give the ideal scenario, which I think is sort of like what we might reach for, if we had all the resources in the world that we needed. So, Pat McGorry, who's a real, pioneer in the world of prevention in psychiatry, has proposed that there be something called integrated youth primary mental health care. And this would, and this is something they've developed in Australia, and then it has actually disseminated to some extent, mostly to European countries and, high resource countries. So this would dispense with the kind of division between, pediatric populations, which is like 0 to 18, and then with this like kind of unnatural break, 18, and above. He says that has really inhibited care for this sort of transition age group that's so vulnerable. And there are various kinds of features that will make it that seem to make this kind of program more accessible and more acceptable to the target population, with youth, sort of input to the design, public education to reduce stigma and help people understand the importance and need for this sort of care. A lack of emphasis on diagnoses, a more sort of, as Corey was talking about, transdiagnostic approach. And then, a heavy sort of investment in digital mental health and real investment in programs in schools and workplaces. And then, evidence-based prevention programs. So I'll refer you to this article that just came out very recently in World Psychiatry for more details about this. But today I'm going to talk mostly about prevention, specifically prevention programs and how they might work if we really implemented this in the US. So just to step back for a second, I think you all are probably very well aware, but it's good to kind of remind ourselves that prevention in medicine over the past, 100, maybe, more like 200 years has been this incredible success story in terms of its effects on the incidence of disease and the improvement in overall well-being and mortality, in the entire world, So, I mean, there are earlier examples than the examples I have listed. Like one huge one, obviously, was, potable water, clean drinking water was a huge advance that improved people's lives and their mortality. But then things like prenatal vitamins, childhood vaccinations, smoking cessation, and all the different tests that we are able to take that give us a sense of our risk for disorders and cancer screening and that sort of thing. And then, of course, the most salient recent example are all the things that have been done to prevent COVID-19 that were, whatever you might say about when and how they were implemented, in the end, they were incredibly, incredibly successful. And I think we're all grateful for those. So why don't we have something like this in the domain of mental health? Psychiatry for some reason is not, up to speed with the rest of medicine in terms of this. And this is kind of a longer conversation that maybe we'll have time at the end to talk about what the reasons are for why psychiatry has lagged behind the rest of medicine in terms of really developing testing and actually implementing preventative mental health care. But the fact is we don't, even though there's been a lot that's been studied, we don't actually really have this yet. So, to just extend the analogy of a vaccine for a second, how can we do this? Like what would be a good way to do this? And I think it helps to think about like exactly, when or how a mental health condition develops. So if you think about just over time, say during adolescence, people have little symptoms of, depression, anxiety, maybe some mild stress, things like that. These things wax and wane. It's hard to tell whether they actually, are indicating real risk for something more serious or not. But sometimes what happens is some kind of major stressor occurs. And then this precipitates something that's a little bit more concerning and impairing for people. So one way to think about this, one model, is to think that there's something that we could do during this period that actually allows people to manage these stressful events, which everyone has in their lives, right? And then leads to a different outcome, leads to resilience rather than illness. And we'll talk about what that means, resilience, in a minute, because I know it's a word that's thrown around quite a lot these days. So this is sort of the general overall model. And then just to think about, just for a second, what kinds of prevention are there? So in general medicine, there's essentially three categories of preventative interventions. There's universal, which is essentially something that you give to the entire population, like putting fluoride in the water, or advertising on TV or out in the world, to tell people about the dangers of smoking, for example. And then the next type is called selective, where you might target a high risk group, but people who have essentially silent risk factors. Say if you have a family history of an illness, or a genetic marker or something like that, then you might have more monitoring or some preventative interventions that are kind of not very difficult to do. And then indicated prevention, which is where a lot of the efforts have been in psychiatry. So indicated meaning that you already have some symptoms or some signs of having an illness. So for example, if you had a cardiac stress test and you showed some abnormalities on your EKG, then something needs to happen to prevent you from having a heart attack. Or you have an abnormal pap smear or something on a mammogram that needs to be addressed. Those kinds of things. So just to go through the different kinds, so universal prevention, how could we do this in psychiatry? Well, there are some things that are being done, like, for example, depression screening in primary care, and there's some school screening that happens. But this could happen in many different community settings, workplaces, online, people, areas out in the community like shopping centers, libraries, places of worship, but probably mostly schools and primary care. So selected or indicated prevention. So one big question is, what's the evidence that these things work? So I think some of the strongest evidence comes from studies of depression. The evidence that we can prevent depression, particularly in people who have some risk factors, either a family history or some prior history of depression, is pretty strong. There have been a number of meta-analyses that have shown that psychological interventions like a cognitive behavioral therapy, either group or individual, can reduce the risk for later depression by perhaps 20% or so. And then there's some evidence that exercise has and this is one example, this is a famous study of a depression prevention program that was conducted in adolescents that showed that CBT prevented the onset of depression in adolescents who had risk factors, either a family history or some prior history of depression. And then some evidence, as I mentioned, supports the efficacy of exercise in preventing depressive symptoms. So I think that this evidence is very strong. And so I think it could support more dissemination of depression prevention programs. And then indicated prevention for psychosis. So there's been a huge amount of research on this topic, mostly focusing on this sort of category of risk called clinical high risk. And these are people who have subclinical symptoms of psychosis. So they have mild symptoms of maybe paranoia or maybe some perceptual aberrations, but they're still able to function and they have some insight about those experiences. But they're pretty symptomatic in that they're distressed, they're seeking help, they may have some progression, they're showing some worsening. So they're kind of on the cusp of potentially developing an illness. So studies of this particular risk group have found that maybe 15 to 20% of people, even who are that symptomatic, actually end up developing a psychotic illness. But perhaps more importantly, a very large percentage of them, you can kind of see it in this diagram, these people in the green, are people who develop non-psychotic psychiatric disorders. So people in the clinical high risk category are generally sort of transdiagnostically, as Dr. Cather was saying, are transdiagnostically at risk. And the evidence that something can prevent, an intervention can prevent this transition to psychosis in this group is kind of mixed. There's some argument right now in the field about whether we can prevent psychosis in people in this CHR, as it's called, state. But there was a recent meta-analysis that suggested that cognitive behavioral therapy, again, can potentially benefit these folks and maybe prevent the development of psychosis. So this is really exciting, and a lot of people are following up this important evidence. So let's now get into the details a little bit. How do we develop a preventative intervention? What should it look like? And so, as I showed you in this kind of model of stress, sort of maybe catalyzing the development of a more serious mental health condition, that perhaps improving people's ability to manage stress might have a beneficial effect. And that's where this concept of resilience comes in. So the pandemic is a really good example, because there have been a lot of a stressor, essentially, that everyone has experienced. Obviously, some people have experienced a lot more stress than other people, depending on their circumstances. But lots of people experienced pretty intense stress kind of at the same time. So it's almost like a natural experiment. And so a lot of studies have shown, some people have really had a lot of symptoms during the pandemic, but maybe have seemed to recover somewhat. Some people have had ongoing issues despite whatever's going on in terms of the state of the pandemic and the world. And then some, despite, a lot of challenges, have remained resilient in the sense that they had a major stressor, but they were not, they weren't impaired by that. They didn't develop symptoms in response. So there have been many studies of people who've dealt with stressors during the pandemic, say frontline healthcare workers and other populations. And many of those have shown that resilience is a major protective factor. But what is that? What is resilience? People are always using this word, right? So one way to define it is it is essentially the capacity or process. Some people talk about it as a dynamic process of bouncing back or adapting during or following stressful situations or crises. And it's thought that some of it is just, you're born that way. Some of it is determined by genes, but a lot of it isn't. When you see 30 or 50% determined by genes, a lot of it is actually something that can change, depending on circumstances or your situation, but also maybe there are things that we can do to change it. And, our resilience changes from day to day. And of course, I want to emphasize that there is, of course, a relationship to the severity of the stress. One cannot expect to be fully resilient when faced with a major loss or trauma or uncontrollable events. Really suffering or being distressed during stress is completely normal. And that's part of being resilient, actually, is to acknowledge that and embrace that. But we'll talk about that more in a minute. But I just wanted to make sure to say that. So as I mentioned, resilience, the contributors to resilience include things that we can change and things that we can't change. So we can't change our genes, we can't change our childhoods, but maybe we can change a little bit our patterns of thinking, and that would maybe have an effect on our brain, just in terms of their close relationship. So again, what is resilience? So there's the scale that is used a lot in resilience studies, the Conrads-Davidson resilience scale. And that maybe gives us a clue as to what resilience consists of. So it includes things like, I am able to handle unpleasant feelings like sadness, fear, anger. I have a strong sense of purpose in life. I feel in control of my life. Even when things look hopeless, I don't give up. I'm not easily discouraged by failure. During times of stress and crisis, I know where to turn for help. Under pressure, I stay focused and think clearly. And I always think of the example of Andre Agassi, who came back from behind in this French Open final. I don't know if you guys, any of you follow tennis, but it was this remarkable display of sort of persistence under pressure. So what are some of the things that increase resilience? Well, we know things like physical activity, getting good sleep, nutrition, social connection, support, humor, pleasure, actually having fun, and then things like having a sense of purpose, meaning, spirituality, optimism, gratitude. And some of these things include certain ways of thinking or experiencing one's life in the world. And some of these things can be learned, actually. So now I'm just going to talk very hopefully briefly about some of the specific work that we've been doing in our program. But these are just examples of many different kinds of work that are being done along these lines. But our program has done a number of studies, focused primarily on indicated prevention approaches. So developing prevention oriented interventions for people who, either adolescents or college students, and more recently, we've also focused on healthcare workers who have some symptoms or some mild sort of signs that maybe they might be at risk, although we keep the bar pretty low. So we've been developing resilience boosting psychological interventions for those folks. And one risk factor we focused on in a few different programs is these symptoms, which are what we call mild psychotic-like symptoms, because they're not really psychosis per se, because they're extremely common, as you can see in this graph. Something like almost 20%, I think it was 18.8% of high school students in this survey that Randy Schuster's group conducted of Boston area high school students. They endorse at least one of these symptoms. So very common, they're usually transient and benign, but they are actually associated with some amount of increased risk for developing a serious mental illness, more likely depression or some mood disorder rather than psychosis. But the level of risk depends on how severe these symptoms are, how persistent they are, and how distressing they are. So we have one program called Resilience Training that we have mostly provided to college students. And it's very brief, actually. It's 4 weeks long. It's a group-based program. There are, maybe 7 to 12 participants with 2 facilitators. And this includes these meetings, we have didactic information about certain skills, which I'll tell you about in a minute, experiential exercises, discussions, and then we assign home practice. We use a very collaborative design, especially in the beginning, but we still, after every session, get input from participants about what they liked, what they didn't like, and how to improve the program. And we used to deliver it solely in person, but lately we've been delivering it by Zoom, and it's been just as effective over Zoom. And I just want to really mention the team here. I won't go into all of their roles in the interest of time, but this has been a huge group effort. And so, Annie Burke, Nicole Dutorre, and the other folks have done amazing work in developing and implementing this program. So this program includes 3 evidence-based skills. This is what we focus on teaching: mindfulness, self-compassion, and mentalization. And I'm not going to talk too much about what these are. I think maybe some of you all are familiar with them, but the common theme really is focusing on improving emotion regulation and social functioning. So all of these skills have been shown in many studies to improve those things. And if you wanted to make it extremely simple, one kind of common element to all of it is the idea that what we resist persists, that we really need to develop greater awareness and acceptance of whatever we're experiencing, and then obviously greater compassion for that experience, and then greater awareness of what other people may be experiencing as well, and all the possibilities for that. So just to cut to the chase, we've done a couple of different trials, but this is our most recent randomized waitlist controlled trial where we showed significant increases. These solid lines are the group that show the pre and the post data for the people who received resilience training. You can see they showed increases in resilience, mindfulness, self-compassion, while the control group that received nothing during the waitlist period didn't show any changes in those skills and the ability to, the capacities associated with those skills. And then we saw significant reductions in psychotic experiences, distress from psychotic experiences, and also symptoms of depression and anxiety. And lastly, we saw that these effects, at least for psychotic experiences and distress from psychotic experiences, were maintained actually 1 year later. And this was a 4-session intervention. We saw these effects maintained 1 year later. And right now we're analyzing our longitudinal data. We have a sort of large amount of data at this point of people who've done this program, and we're seeing some preliminary evidence for beneficial effects on GPA, use of mental health care services, and social functioning. So stay tuned, and we'll have more on that at some later talk, perhaps. So here's just a really quick video of people talking about the program who did it.
After completing the program, I have consistently used the various exercises that were taught, such as the mindfulness exercises, in my everyday life.
I just think that this course is just really important for students, just to kind of keep themselves from feeling like everything is attacking them, and being able to have ways to wind down and deal with it, and just being able to understand themselves to a higher degree than before.
I think courses like this are very important, especially if you're coming in as a freshman like I did, because you don't really know anybody, or you might not know what to expect from college.
It was really helpful for me to see my problems in a new light, and also to be able to discuss them in a group situation where other people who are in the same situation as me for a bunch of different reasons, and like understand me for a bunch of other different reasons, we get to work through those problems together as a group, and I get to have that fresh perspective. That was really amazing for me.
Especially during this year where students are even more isolated due to the pandemic, it's important for this course to continue teaching students how to navigate these emotions and stressors. I have benefited so much from this course, and I know others will too.
So yeah, I realize that I am running out of time. So I'm just going to tell you about this other program that that we've been conducting in adolescents. And we've done 2 iterations of this program. It's called Living in Families with Our Emotions Life, and it's in middle school age adolescents. And it's similar to the resilience training program, but it's actually 8 sessions, and we have 3 parent sessions. One of the 3 parent sessions also includes the adolescents. And these sessions focus on emotion recognition and regulation. We've done one program over the years in the Chelsea Healthcare Center Department of Pediatrics, and we screened the kids during their annual well visit. And these kids were predominantly Latinx, their families were Latinx, and so the parent sessions were conducted in Spanish, and in both the parent sessions and kid sessions had one bilingual facilitator. And I just want to again acknowledge particularly the person who co-led this program with me, Corey Cather, and then the amazing team. And it's a much larger team than this, but that I wanted to at least acknowledge some of the people who've done a lot of hard work. And then we've also done this same program in Boston area middle school kids, same age group, but this time we worked with my co-PI on this project, Randy Schuster, who has this very large screening program across Boston area middle schools and high schools. And so those are the 2 sort of ways we've implemented this program. And during the pandemic, we have actually conducted these groups via Zoom. So I'm going to skip this slide. This just gives you a little bit more background on the model that we used to focus on emotion recognition and emotion regulation, and that we actually train the parents to also be kind of a regulator of their kids' emotions, that it's a kind of a reciprocal kind of process, but you can read about that in some of these references. We'll send this along. So here's just a brief video of one of the parent participants of this program.
I always knew the mind and body were connected, but this resilience program, it broke it down and demonstrated it in so many ways that it was amazing to learn how our emotions become thoughts that then cause physical sensations in the body that eventually lead to our change in behavior. I think this process, this step, it really helped us appreciate our daughter and then approach her with compassion, understanding, and then the most important thing, with less judgment, and later with no judgment.
And then this is just a very brief video, showing one of the exercises to teach emotion recognition to the kids.
Let's see what happens when Marco gets home that day. Hi, honey. How was your day?
Leave me alone! I'm so stupid! Ugh! Ugh!
Which emotions do you think Marco is feeling?
And this just shows some kind of early data. These are single arm. We did a single arm study for each cohort, the Chelsea cohort and the Boston area middle school cohort. But you can see we see significant effects on anxiety and depression, social problems in the Chelsea group, and then depressive symptoms in the middle school Boston group. And we see very strong effects on suicidality, which was very interesting to us. And then I'll just sort of skip this, but this is a kind of cognitive neuroscience measure of a social attribution bias. And we see this increase in a positive social attribution bias, in that kids are more likely to label neutral faces as being happy, which was interesting. So lastly, I'll just mention very briefly the last intervention that we have been working on most recently, which is to do our resilience training program within virtual reality. And people really seem to gravitate to this, certain populations of adolescents and adults, because it affords a certain amount of anonymity. You can be in the group as an avatar that doesn't look like you, doesn't have your name. And so there are a lot of and also we can do exercises in VR that we cannot do in real life. We can use VR to do kind of fun, cool things where we can switch bodies and things like that. So we've just, and this is a immersive interactive multiplayer VR application. So this is, I think, my second to last slide. This shows the VR, the environment. It just gives you a quick flavor of it. You can see we have 3 different environments in virtual space. So we have an outdoor environment, college kind of common room, and then we have one that's sort of tailored to healthcare providers. And we've done some pilot work showing that, again, we show reductions in symptoms after this program, which is called Room, Reconnecting with Ourselves and Others in Virtual Meetings. So yeah, so to close, just to summarize what I've talked about, youth mental health is a major area of need and opportunity, as we've talked about a lot today already. Resilience is defined as the ability to weather stressful experiences. There are many factors that contribute to it, and some may be changeable. Some of the ways that the mind interprets experience and the body's response to stress can contribute to resilience. Cognitive behavioral therapy and other psychological interventions have been shown to reduce the risk for developing or the severity of mental health conditions. Even very brief psychological interventions like the ones that I described to you that we've been working on can positively impact resilience and mental health. A lot more work is needed, though, as I'm sure you can tell, to determine the long-term benefits of the approaches that have been studied so far in the real world, obviously, and then the best way to actually make them available to the people who might benefit from them. So I'll just end with my acknowledgement slide. I think you've seen some of these people already, but thank you so much for listening. And I'm sorry I did go over time. So I'm happy to take questions, or we could just do that over email. It's totally fine.
Let me just ask, thank you so much, Daphne. That was an absolutely wonderful talk, so innovative, and to see those results of a 4-session intervention, reducing distress and then persisting those reductions at a year is just remarkable. And I have a good sense of the amount of effort that goes into this work. I'm just seeing that you're frozen right now, so I'm still speaking for a moment. Let me just, one of the questions is whether or not this training is offered to facilitators currently. And I happen to know that it is not currently offered to facilitators, outside facilitators to learn it, but it is certainly something that we're thinking about, that Daphne's thinking about, because we absolutely need to build capacity. So future opportunities may come. One way to learn more about the resilience program is to go to the MGH Reset website, which I can put in the chat for everyone so that you can learn more about it. I'm realizing we are at the break. We did lose Dr. Holt anyway. Oh, she's back.
I'm so sorry. That doesn't usually happen to me. I don't know how that happened. How weird.
You know, it's not a virtual conference without some blips. That's just part of it.
Yeah.
Let me just ask one question, actually, Daphne, that I thought was a good one. Is this person started, this is a silly question, but there are no silly questions. How do you know that you are preventing depression? Can't prodromal depression only be diagnosed after it develops?
Let's see, prodromal depression develop after it develops. Oh yeah, so you're talking about the word prodromal. Is that kind of what it means?
I think it's a design question. I think it's a question of how are these designs building confidence in the idea that you're actually preventing depression. So maybe talking about the comparison group.
I see, yes. Well, yeah, usually there's a comparison group where people get, something like lifestyle intervention, or they get, nothing, because, a lot of these kids would not be engaged in clinical care at all. So it's actually not unethical to have the control condition be, not very much, maybe one psychoed session or something like that. But yeah, people measure symptoms pre-post, and the treatment group or the prevention group usually shows lower symptoms of depression, or maybe they didn't develop a diagnosis of depression. But maybe one thing that you might be getting at is that one flaw of a lot of these studies is they don't have very long follow-up periods. So can you really call it prevention if you just followed people for 6 months after the intervention or 1 year? I mean, did you really, provide a vaccine, so to speak, that has a long-lasting effects? And I think probably the answer is no, that we don't know for most of these studies, that they didn't have long enough follow-up periods.
Excellent. Thank you, everyone, for your engagement, your questions. Thank you, Daphne, for just a wonderful talk. Very exciting morning so far, or afternoon, I guess. And we're going to go on break now until 2:10. We will reconvene at 2:10, and we have another really wonderful speaker and then an incredible panel. So I hope you all stay tuned. Thanks.
And we are back from our break. So it's my pleasure to introduce Dr. Kathryn Sabella, who started as a high-level research staff member in the Transitions to Adulthood Center for Research within iSPARC back in 2010. She has since obtained her Ph.D. in sociology at UMass Boston and has joined our faculty at iSPARC as an assistant professor. Dr. Sabella employs a sociological perspective and participatory methods in her research. And her research aims to create new knowledge and understanding about the needs and experiences of young adults with serious mental health conditions, and apply that knowledge to the development, testing, and implementation of age-appropriate and culturally appealing evidence-based practices that can improve their lives. Kathryn.
There I am. Hello, hello. Thank you, Marianne. Thank you for that introduction. And thank you all for joining me and inviting me to be here with such esteemed colleagues. I've enjoyed the presentations thus far. So today I'm going to be presenting some qualitative work. So I love some charts and graphs that we've gotten from some of my colleagues today. And now we're going to shift over to hear some of the words and experiences directly from young adults themselves, both in terms of their own experiences as children and then their parenting experiences when those of them are parenting. So I just want to acknowledge the funding for this research study is through the National Institute on Disability, Independent Living and Rehabilitation Research, NIDLR. So this is part of our large rehabilitation research and training center that aims to promote participation of young adults with serious mental health conditions in school and work. Sorry, I just need to adjust something. All right. So today what I'm hoping to do is kind of share and reflect on the diverse ways young adults with mental illness describe, in their own words again, how their families of origin have influenced their own mental health. Also, then I'm going to describe the additional challenges young adults face while parenting with a mental illness, and essentially hope to also highlight how young adult parents with mental health conditions are motivated by their children. So it's not all bad news, and I think that's important for us to remember. So the data I'm sharing here today come from the CHEER study. CHEER stands for Collecting Histories of Employment and Education During Recovery, named by a young adult staff member at the Transitions ACR. The primary goal of this study was essentially to explore and describe the experiences of navigating employment, education, and training in young adulthood while managing a mental health condition. We don't have a ton of research out there on the employment and education experiences of young adults with mental health conditions, but we do have a lot of outcome indicators that show typically they struggle when compared to their peers with other disabilities or without mental health conditions. But the narratives, the voices of those young adults are typically missing from the literature, and we wanted to fill that gap in a little bit. And then secondarily, we wanted to explore the unique experiences or the potentially unique experiences of a subgroup of young adults with mental health conditions who are also parenting young children. This project, like most of the work at our center, is founded on a community-based participatory research framework. So what that means is that this project was motivated actually in part by lived experience of a young adult staff member, or I should say the emphasis on young adult parents. We employ several young adult staff members at our center who are research coordinators and also happen to be young adults with lived experience of a mental health condition. And we had one such young adult working with us who was also parenting young children. And we had young adult staff members really participating in not only the conceptualization of the study, but also helping us with recruitment, conducting most of the interviews, and participating and assisting in the interpretation, coding of data, analyses, dissemination, and even the writing of findings. So this was a qualitative study. So this is a one-time in-person interview. These data, dare I say, feel a little old already. They were mostly collected interviews during 2015 into 2016. And we recruited from the greater Boston and Worcester, Massachusetts area. We wanted to do face-to-face interviews, all pre-COVID. And the interviews were somewhat lengthy. Again, it was one interview, but we modeled it as a life history narrative kind of interview or approach. And so therefore, really, we wanted to be able to sequentially talk to young adults about their school training and work experiences and how those unfolded over time. We did ask them to fill out a brief kind of demographic sheet just to get some basic characteristics about the sample. We asked them to talk about their mental health related experiences, including when they first started experiencing symptoms, what that looked like when they were diagnosed. We asked about their family involvement. And then if they were young adult parents, we also asked them to describe those experiences. So we recruited very much on the ground in mostly community-based mental health service agencies, clubhouses, and some local social media efforts. DMH was a huge partner in this. So not only did we have IRB approval through the University of Massachusetts Medical School, but also through DMH IRB as well, since we were recruiting from many agencies funded by DMH. And we were seeking, I'll say, older young adults. So again, this was a life history narrative. So we wanted to talk to young people that were more at the upper end of what we consider young adulthood, ages 25 to 30, so that they had enough schoolwork experience to kind of describe to us over time. We ended up dropping that age eligibility requirement down to 22 in order to find young adult parents. I'll explain that more later. We wanted them to have some school or work experience that they could share with us, report having been diagnosed with a serious mental health condition prior to the age of 22. So again, they have enough kind of experience with their mental health condition to talk about. And being funded through a disability research kind of foundation or federal agency, and following this idea of mental health as disability in some cases, we also required young adults to meet some criteria for kind of functional impairment. That's basically experiences where their mental health condition has been maybe disruptive to their ability to go to school and work. Could be inpatient hospitalization, intensive outpatient hospitalization, if they're a client of DMH, if they had special education services or needed to take a formal leave of absence from school or work because of their mental health condition. And unfortunately, due to limited resources, we needed all participants to be able to read and understand English and provide informed consent. So these data, I've been mining these data for a long time. Definitely feels that way. So as Marianne mentioned, I somewhat recently got my PhD. So I used these data actually in the study for my dissertation. From sociology was my area of study at the University of Massachusetts, Boston. So my dissertation in 2018 really used 55 young adults in the sample and quantified mostly their experiences in school and work, but also included some thematic analyses in terms of family, experiences with the mental health system, diagnosis, treatment, things like that. It was really top to bottom. Then in 2021, I had published a paper in the Psychiatric Rehabilitation Journal that really quantified the experiences of school and work, because again, with that life history narrative, we were able to kind of trace patterns and also quantify ways in which young adults were experiencing a lot of interruptions to continuous pursuit of school and work. And since we were talking to them about those experiences, we were able to identify themes related to either what helped them continuously pursue school and work, or what were the factors that prevented them from doing so. I'm in the thick of it right now. I'm still in these data with two MSW interns from the Boston University School of Social Work. And we've been doing some qualitative analysis of the experiences and perceptions of mental illness, again, in their own words from young adults in this study. And then I'll also be bringing in data from the subsample of young adult parents. There were 18 in this study. And we very recently published an article in Frontiers in Psychiatry describing the themes that emerged from young adult parents. And I'll bring some of those to you today. So in keeping with today's theme and being asked to participate here, I think I wanted to bring in those dual elements of both young adults with mental health conditions as children themselves, right? And their experiences in early childhood and navigating their mental health condition, and how their families of origin might be influencing those experiences, but then also really talk about the experiences of the young adult parents, since we don't know much about what that experience is like. So consider this kind of a two-parter in that way. So in terms of familial context, and so here I'm meaning more traditional family of origin kind of context, I do want to make this important disclaimer that context does not always equal cause. And I know in kind of family advocacy arenas, NAMI and other kind of advocacy groups, sometimes the family gets, I'll say with air quotes, blamed for their child having a mental health condition or feel guilt, like they did something to cause this. And we know the causes of mental illness are very diverse. So I just want to say here that I'm not inferring by any means that families cause mental illness among young adults. But in this sample and in this study, some young adults do make that connection. And so I'm here to just kind of be the vehicle to share their words with you. And we will also see families that provide positive support. But I kind of just wanted to call this out before I went any further. So to describe just the sample I had, so again, this is all Massachusetts young adults around 2015, 2016. We had 55 young adults in this analysis that I'm covering right now. Average age was 27.5 years old, mostly women, and 75% were non-Hispanic white. I do wish we had more racial diversity here, but most of the recruitment did take place in Greater Massachusetts, Central Mass, which when you look at the demographics based on the census, our demographics of the sample were actually pretty representative of what you find in Central Massachusetts. You'll see here, though, these young people were not making that much money per year. They were between the ages of 25 and 30, and they were making, most of them, 2/3, were making less than $10,000 a year. And in terms of education, I'm not going to get too in the weeds with the employment education patterns we uncovered, but you'll see here almost 1/3 had only high school diploma or less, maybe equivalent or less. And we saw 47% of this sample had attempted college, had enrolled in college at some point, but had yet to obtain a degree. And again, they're now on average 27.5. So the chances of them getting that degree are kind of being reduced every year. But we did have about 20% of the sample had obtained some post-secondary degree. In terms of the diagnoses that they had experienced, this is, again, is all self-report in terms of please tell us if you've been received a diagnosis of a mental health condition from a provider, and if so, which one. On average, young adults were reporting 3 diagnoses, sometimes up to 6. And some of these they considered, co-occurring. In other cases, they did describe experiences of receiving different diagnoses from different providers at different times in their lives. 2/3 of the sample, though, had been living with that mental health condition since under the age of 16. And we see here that major depression and anxiety disorders were the most common diagnoses reported, followed by PTSD and bipolar disorder. And we did see about 1/3 had co-occurring learning disabilities, that should also say including ADHD or autism spectrum disorder. So we did see some co-occurrence in that regards as well. So let's get into the family stuff. Again, with a life history narrative, we were able to kind of start with the interview, in the interview script, asking, where they live now and who they lived with and what their family upbringing kind of looked like. And what we saw was that 90% reported a parent or sibling with mental illness or substance use, more than 90%. And some report parents that were in denial, maybe air quotes there, that they had a mental health condition or refused to seek treatment if they did acknowledge it. So in this case, this quote on the left, sorry, I thought I had animations in here. I lost them. This first quote says, well, my dad, I never really knew him sober. He would just drink. He would go to work, come home, drink, kind of just sit and watch TV. I'm assuming he did have depression or some kind of mental illness, and he just didn't know how to cope with it. So that was always a struggle because he was there, but he wasn't there. So I just kind of dealt with it the best I could and tried to keep busy and do what I had to do. Another young adult describes, my mom's alcoholism was definitely her self-medicating from her depression. I would get depressed and upset when I'd come home from school and she was drunk. I didn't like that at all. And I know that's probably a lot of the times why I was depressed. I didn't have someone to go home and talk to. I didn't have a huge support system at first. And from 12 to 14, when I started seeing and hearing things and being really stressed out before I told anybody about it, I was very isolated at home. So I bring this here again, these are young adults' own words, but this experience of maybe something going on in the family that then makes the young person feel isolated and or be unable to really focus on what they need to deal with. There was definitely a lot of trauma in this sample. Family, and this could be extended family as a source of trauma or abuse, was in about a quarter of participants. So about 25% reported sexual trauma by a family perpetrator. 36% reported emotional, verbal, or physical violence in the home, that either they were the victim or they witnessed it, and maybe a sibling or the other parent was a victim. And this family context of trauma, many of us probably have been exposed to this in one way or the other, leads to needing to keep abuse a secret. Side note, I recently got to see Ashley Judd speak. She's an activist and actress, and she was in the news recently because her mother passed away. Her mother was a famous singer. And I saw Ashley Judd speak about a week before her mom passed away. And if you've read their memoirs, there was a lot of trauma, intergenerational trauma there, but she spoke a lot about how family secrets cause shame, and shame puts pressure on young children to keep that trauma or that abuse a secret. And it just kind of is a breeding ground for some of these psychosocial distress that we were just talking about. This young person says, for about a decade, I kept it a secret because I was afraid of anyone finding out. Anytime I would have my bursts of sort of panic attacks or wanting to cry, I'd sort of sneak off to do it myself. This other young adult said, my brother sexually abused me, and for a long time it was like, oh, it didn't happen. It didn't happen. And it happened when I was young, from like 6 to 10, but it was always like, what are you talking about? Like, this didn't happen. If it was happening, why didn't you say something? So unfortunately, this need to keep these occurrences secret were definitely kind of a festering ground for some of the challenges that some of these young adults experienced. And again, these early childhood experiences did seem to impact their ability to seek help or to speak out. Many young adults talked about not wanting to add trouble to an already stressed family system, or not wanting to be like their own parents, and they start to see themselves decline in a way that they recognize. One young person says, my brother had been diagnosed with bipolar disorder, so I had seen them, parents, kind of having to deal with that, and I just didn't want to add to the problems. Another young woman said, I fought having the issues because my mother had a lot of mental issues growing up, and I didn't want to, quote unquote, be like her. So it took me a long time to accept I had any kind of problems, so I wouldn't go see anybody. Finally, again, this is not all bad news. And we saw that about half of the sample reported their parents being supportive and positive in present day, even if there was challenges in the past. And many times families and parents were considered primary advocates. Ashley Judd talked about this when I saw her speaking about how, she had a very rough upbringing. I don't think I realized how much trauma she had in her childhood, and some of it was at the hands of her mom and dad. But through her own recovery and support systems, and she was able to recover those relationships with her parents in older adulthood. So those kind of familial recovery is possible, and in other cases, not possible. So this young adult says, my mother we are really close, and she has done everything to help me get through my difficulties, and is just an incredible woman in that way. And I'm really blessed to have her. Another says, I know my parents have done a lot for me. I'm always really appreciative towards them and try to do a lot for them now because they were doing so much for me before when I couldn't handle it. So in terms of kind of takeaways from what we're learning, and this is just a snapshot, and I'm excited to be here to share this snapshot with you because these data haven't really been published, is that in this sample, again, 55 young adults in Massachusetts, young adults did commonly describe familial mental illness, substance use, or trauma. And sometimes those experiences were tied to their own mental health challenges, and or how or when they disclosed their mental health challenges. And it does look like there was maybe some missed opportunities in families of origin. And we know, or we're learning more about intergenerational trauma and how adverse childhood experiences, ACEs as they're known in research fields, the mechanisms by which those early experiences shape adult outcomes. And I think these quotes here hopefully add a little flavor to the data that we do know. But we also know that families can be positive sources of support, even when those challenges were present or are present. I think I use this term a lot in recent presentations, but one size does not fit all. And the need to have highly individualized understanding of who your client is or your patient, and what their childhood looked like or does look like, and what their family looks like now. And I would also say, I see this, the sociologist in me needs to say that some of this is also framed by social context and socioeconomic status. So I did conduct a couple of interviews, and I remember within 1 week, I conducted an interview with a young white woman who lived in Beacon Hill, who came from an upper middle class upbringing from the South Shore. I mean, she was lovely, but clearly had a level of affluence in her family and associated support that had helped her get where she was. And then a few days later, I was at a group home, a DMH group home on the North Shore, and I was interviewing a young man who had just been released from prison, who had grown up in very dire circumstances with a lot of abuse, physical, mental, and sexual trauma. And his life had taken quite a different trajectory. And he at that time had no relationship with his mother, and probably for the better. So I just bring you those two illustrative examples to remind us that one size does not fit all, and people are not given a fair chance either. And we need to be individualizing our services with that in mind. So what about young adult parents? So I'm not sure if Kate Biebel was a colleague of mine, a co-investigator on this project. She is now at MRC. Joanne Nicholson, who used to be at UMass Medical School, has done a ton of research and helped implement some services within DMH and other places to support parents with mental illness. But what about young adult parents, and why do we want to think about young adult parents? I see it as a big Venn diagram. Parenting is hard. Parenting is stressful. Parenting young children. I'm kind of coming out of the tail end of that thickness, if you will. It's tough, right? And managing one's own mental health condition can be challenging, especially when there is a condition there, or a disabling condition there, or one that requires a lot of treatment. It can be a full-time job. And then you have stigma or fear of discrimination, not only because of your mental health condition, but maybe because of your parenting, because of the fact that you are parenting with a mental health condition. And we know that that stigma or fear of discrimination keeps many parents quiet in terms of what and how their parenting is going when they're also managing a mental health condition. And then you add young adulthood to it. And, through the work of our center and others, we know that young adulthood, in the last 50 or 60 years has become this expanded period, this emerging adulthood period. The normative milestones of young adulthood are happening later and later. And that also includes marriage, home ownership, but also having children. The average age of first childbirth for both men and women has increased several years since the 1960s. And for those of us who are old enough, you might remember the big push on preventing teen parenting, preventing teen pregnancy in the 80s and 90s, when the pregnancy rates among teens were at the highest point. And they have since lowered. And I think that is as a result, the reasons why the teen pregnancy rate has lowered are multifaceted, a lot of social forces going on there. Some of it is because of the public health response in terms of preventing teen pregnancy. But culturally and societally, we've seen this young adulthood period elongating. And so it's possible, or I think it's possible, that some young adult parents, regardless of their mental health status, might encounter some of the same challenges that teen parents did of previous generations. Because the cutoff of teen parenting was it was based on not only that teen, 19 years and under, but also based on the distribution of what the average ages were of first parenthood. And we're seeing that age creep up. So now a 21-year-old or a 20-year-old might not technically be a teen parent, but we might want to be worried about them. We might want to be thinking about what supports they need, regardless of if there's a mental health condition. So in our study, we oversampled to find 18 young adult parents in the greater Worcester, Massachusetts, Boston area. Within our sample, we did lower that age range to 22 to 30. I'll talk about that in a minute, I promise. And so the average age of the parent subsample was 26, 25.89. 83% were women, but we did have a few fathers in this sample. And 40% of these young adult parents had become parents under the age of 20. So they did fit the criteria of a teen parent, if you will. Half of the participants only had one child, and 3 parents in this sample did not have custody, and only one of those had visitation. And these are mostly the fathers. In terms of the diagnoses, we saw actually anxiety disorders being slightly more common in this group than major depression, but higher rates of PTSD and bipolar compared to the larger sample as a whole. We still see this group mostly making less than $10,000 a year, and the education level completed is a bit lower, because this is what we're saying with teen parenting. One of the concerns about teen parenting was, oh my gosh, these parents, these kids aren't finishing their education. And now that we know, on average, higher education takes more like 6 years to complete than 4 years. And so we start thinking about 20, 21-year-old, 22-year-olds, it's likely they haven't finished their post-secondary education, if that was in the cards for them. So in this group, we did see 44% of the young parents had only a high school degree or less, and fewer of them had received a post-secondary degree. So here's this note on recruitment. We ended up lowering that age range to 22 from that original lower age range of 25 to 30. And that was because we were having trouble finding young adult parents with serious mental health conditions. And by lowering the eligibility, we thought we might just open the pool of potentially eligible participants in the area. Also, though, as we started to realize we weren't finding these young adult parents through our more traditional means of recruitment, i.e. outpatient mental health, community-based treatment programs, or clubhouses, things like that. We started doing some research and trying to find some recruitment partners that were more like young families or young parent support groups. And there weren't many out there. And then the ones we found were still focused on teen parents, where the cutoff was like age 21, maybe 22, maybe 23. And we still struggled even after we lowered that age limit. And so we realized we needed to kind of widen our pool, our recruitment pool, to find these young adult parents. And in talking to some colleagues at the medical school who are doing work in trauma and familial trauma and childhood trauma, we went to some of the family resource centers in Massachusetts that support families in a broader sense. And then we also had a lot more luck when we went to SMOC, which is in Framingham, the Southern Middlesex Opportunity Council. And they are a human services organization that focuses more on low income and disadvantaged families and individuals. And that's where we found a lot of the young adult parents. Also through Wayside, which is also in Framingham. And this is very anecdotal, so don't get me wrong, I'm not trying to make generalizations, but there was something going on there where these young adult parents weren't necessarily going to therapy every week for their own mental health condition. Or if they were, we were having trouble finding them. But once we went to social services that serve the family as a whole or provide more basic needs like housing, food, shelter, maybe employment, things like that, that's where we found more of the young adult parents. And I that sticks with me, and I think it's worth mentioning here. I will say, it turns out at the same time or around the same time, DMH has, several young adult access centers. And I think this was around the time that U4 were at the center in Lawrence, that was starting up. And since then, we know that they actually ended up serving a substantial group of young adult parents in their access center model, which again is low barrier. Oh, well, not again, it's a low barrier model, kind of a drop-in model, but also it provides young adults access to multiple domains of life supports. So it's not just mental health counseling that you can get a referral for, but also housing, food, other, childcare, things like that. So that's worth mentioning. What do young adult parents say? Well, not surprisingly, managing symptoms of a mental health condition while parenting can be difficult. Some young adult parents talked about their inability to be fully present, or how parenting stressors can trigger their symptoms. And often these experiences were talked about in a cloud of guilt. One young woman said, I start slacking on my kids and I know he'll get restless with me and he'll be like, Mommy, you're not playing with me anymore. You're not doing anything with me. And that kind of like puts it into perspective. So she's talking about when her depression gets really bad. Another one says, I feel like when he is sad or when he is sick, my anxiety is triggered by that. It's like I try to do as much as I can to be able to help him or the situation because I didn't have that. So again, another reflection back on her own childhood and the ways in which she's seeing that reflected back to her. And of course, like I said, managing a mental health condition, what's happening here? Managing a mental health condition can be tricky and time consuming. So if a young adult does need to be hospitalized or receive intensive treatment, that can be very disruptive to their lives, but also the lives of their children. So this young adult was saying, having to stop everything because I needed to be hospitalized, I've always had kind of a little bit of guilt. I feel like in the back of my mind, every time I get hospitalized, whatever I'm supposed to be doing is just going to have to stop until I come back. And that can be stressful. But children were talked about often as a motivator for recovery. And I think we've seen this in the literature on adults with mental illness who are also parents. And I think it makes sense as a parent myself. Children can be a motivator to stay well, to stay healthy. And children can provide a sense of purpose and responsibility. One young person says, when I get those suicidal thoughts, I need to think about what is there to look forward to. And that's easier to think about when you're thinking outside of yourself, at least for me. My daughter made me, especially with her dad not being stable. It would be selfish for me to leave because then where would that leave her? Another says, after I had my son, I refused to not be able to provide for my son. It's not just me anymore, my family, Even though I have my depression and my anxiety, that was like a weight on my legs, I still go forward. It's beautiful imagery too. But not surprisingly, and again, similar to the literature on older adults who are parenting while managing a mental illness, several young adults, mostly the dads, reported real experiences of being discriminated against or the fear. Many young parents talked about the fear of stigma or discrimination, the fear that their kids would be taken away from them. This young man says, I've definitely been discriminated against by the judge. It was horrible. They talked to me like I was 5. They look at me like I was a disease of a father. I wanted to be there for my kid, but was never given the opportunity by the courts to do so. So wrapping up here, from young parents, I think generally speaking, we saw some similar themes to those of older parents with serious mental health conditions or mental illness. But I still tend to think that being a young parent may also cause additional strain, and we need further research to understand the intersection of education, employment, and parenthood. And that parenting is stressful, but also doable for young adults with mental illness, just like employment is stressful but doable, or education is stressful but doable. And children can motivate young parents to stay healthy and get support. Final quote here is this beautiful quote: having a mental illness and being a parent is possible. You don't have to be ashamed. I've met a lot of people who have had bad things happen to them. They're afraid that they won't be good parents, but just because you have PTSD, It doesn't mean that your child is going to go through that with you. It doesn't mean you're bad. You can still be a great parent regardless of what your mental illness is. So in terms of your takeaways here, I would just reiterate that one size does not fit all, that intergenerational challenges of substance use and mental illness, these stories do tell us that there are opportunities to intervene. I think, again, as a sociologist, I think there are intergenerational evolution of understanding of mental health and mental illness. I think those in a generation or two older than me, and or what my parents' generation, you didn't talk about feelings, you didn't talk about mental health. Mental illness was not part of your day-to-day dialogue, and it is now more. And so I do wonder what it's going to look like over time. But I think we do need to recognize how families of origin may have contributed to experiences of mental health conditions. And again, young adult parents may experience additional challenges while navigating a mental health condition. And parenting, by no doubt, creates additional stressors, but also can add additional motivation. And I think comprehensive and that integrated care, the ability to kind of do some interventions at the family level is really important, but we have to remove the stigma and the fear of discrimination from those conversations as much as possible, which in and of itself is a huge undertaking. So with that, I will say thank you. My email's here, happy to chat further. I also put up a couple of the articles that I mentioned, and that is that.
Thank you, Kathryn. It's a very rich picture of family and young adulthood among young adults with serious mental health conditions. We have not a lot of time, but we have one question that's been posed by somebody in the audience, wondering if you know, how does DCS manage these families where the parents are struggling with a mental illness?
You know, I can't speak knowledgeably about that. I will say that parents with mental illness do have legal protections, and I know of young adults who are parents living with mental health conditions who have struggled with their DCF cases and where and how they are perceived. And sometimes, you know, seeking out legal advice if you are a parent or working with a parent who is interacting with the DCF system is important, just in terms of advocacy and making sure all sides are considered. I don't think there's a one size fits all. I tend to think there shouldn't be. And I think the role of DCF typically is to get to know the family and what's happening in the family and who's involved, who the players are, and also identify extraneous potential support that's ancillary to the family. And so that's my hope, is that they can help identify supports for the entire family. What it looks like on the ground, I can't speak to, really.
Sounds like there's a lot of work left yet to do to understand what are the best supports for young adult parents who have a serious mental health condition while they're parenting young children.
It's complicated.
Thank you.
Yeah.
Thank you
You're
so
welcome.
much.
Thank you.
Okay, thank you so much. And again, I think we have really wonderful continuity between the presentations. That was a fabulous look at people's experience as parents when they have a mental health condition. And we are going to amplify that with more voices. Before I start, I have to first introduce the incredibly courageous team that is going to present to you today, both live, some of them, and some of them have also appeared in the videos that you're going to see. So I have to start with my very close colleague, Dr. Ren Whitman, who is going to moderate this panel. And Ren Whitman is a senior peer consultant at our center, the MGH Center of Excellence, and she also chairs the Metro Boston Recovery Learning Community, as well as consulting to the Southeast Recovery Learning Community. She holds a Ph.D. from Harvard University. She has an MBA from Boston University, and she's a certified peer specialist. In her spare time, she's an avid swimmer. I'm going to now take the time to introduce each of the panelists, even though you won't see them quite yet. Again, they've made an amazing contribution in being here today. And I think it's important that you know them a little bit as people. So Dee Logan is one of our panelists. She is the project manager for the Implementation Science and Practice Advances Research, iSPARC, at UMass Chan Medical School. She has led the knowledge translation activities. She develops printed materials, video production, social media, webinars, and e-newsletters for iSPARC for the past 7 years. She co-directs iSPARC Stakeholder Engagement Board, and that mission is to really lead mental health research community in working in partnership with people with lived experience, as well as families and agencies. She herself identifies as someone with lived experience of a mental health condition that began in early adolescence, and she is the child of parents who had their own mental health and substance use struggles. Next, you're going to meet Joshua Calarino. He is an advocate. He has worked as a lead peer specialist, a peer evaluator, and a training coordinator. He has worked as a consultant for SAMHSA and the National Council for Behavioral Health. He's worked very hard to make positive impacts in the system of care, both at the local and national level. He attends stakeholder meetings, presents at conferences, uses his lived experience to help systems, and he won the Young Adult Leadership Voice Award from SAMHSA in 2016. John Delic is a college student attending Cleveland State University. He will graduate this spring and plans to go to graduate school in the fall. John also works at the Youth Move Ohio, where he has been helping to develop Ohio's first youth peer support curriculum. He enjoys spending time with his friends and family, playing sports and exercising. Heidi is a fourth-year grad student in clinical psychology with a specialization in neuropsychology. She has a master's degree in cognitive psychology. She's the only child to the most wonderful mother in the world and is participating in this panel because her mother has struggled significantly with mental health challenges for many years. Importantly, through these experiences, Heidi's mother has taught her invaluable lessons about hope, courage, creativity, resilience, identity, and unconditional love. Ren Whitman is a social worker in private practice who works with adolescents, young adults, and their families. Ren specializes in working with members of the LGBTQIA+ community and helps clients through the many developmental issues associated with these identities, including identity formation, understanding and improving family dynamics, and navigating difficult emotions skillfully. She lives in Northampton, Massachusetts with her blind beagle Henry, and the two of them can often be found sniffing out new trails or curled up by the wood stove. And last but not least, Jonathan Burke lives on Martha's Vineyard, works at the Oak Bluffs Public Library. He has two children, Peter and Maggie, ages 19 and 21, and a dog, Beckham. He loves the outdoors. He recently started writing an outdoors column on hiking, biking, kayaking for a local newspaper, and he writes poetry. Jonathan is in recovery from delusional disorder and obsessive compulsive disorder since he started treatment about 14 years ago. I'm going to turn it now over to Ann Whitman.
Thank you, Corey, for those very personalized introductions. That was great. And thank you for all the presenters in this conference today. I think you've really laid the groundwork for what we're going to talk about this afternoon, especially Kathryn Sabella, who just recently completed her talk. I think it will give some voice to some of the things she was talking about. We're going to show you two short videos. The first video will be featuring parents who have lived experience with mental health and substance misuse challenges. And the second video will be interviews with their children and their experiences in the family with someone with mental health issues. This will be followed by a panel discussion. So I want to give you a little bit of the history of the two videos. 4 years ago, the MGH Center for Psychosocial and Systemic Research was a recently funded research center by DMH. And one of the first things we thought we would do is go out and hire 8 peer consultants to help us lead our research interests. And these peer consultants were from a very diverse group and came from across the state. One of the first things the peer consultants thought we needed to do was to interview the the recovery communities across the state of Massachusetts to find out what their needs and interests were. And after doing this, their needs and interests would guide our research efforts and projects over the next 4 years. We set out to survey the recovery learning communities first and foremost, because our peer consultants had connections with these recovery learning communities. We had interviewed 159 participants in listening groups across the state, and we designed the research questions and executed the groups with the help of a postdoctoral researcher and a clinical research coordinator. Out of these needs assessments, we found many items, but one of the most interesting ones was that parents with mental health and substance abuse conditions faced a lot of stigma and also could use some support in parenting. Now, this really aligned with the interests of our 8 peer consultants, most of whom are parents. And so we decided to create a video about parenting. When the video was completed, we showed it in over 30 venues, and it was so well received that the participants in the seminars where we presented it asked for us to create a video of the children's experiences of these parents. The parent video was filmed pre-pandemic in a shared space. The children were interviewed via Zoom during the pandemic. And we want to thank very much Lisa Lefebvre, Hannah Skeese, and Stephanie Shu for their editing capabilities of these videos. I also want to thank Corey Cather and Derry Stasel for their guidance and continual enthusiasm about us putting these 2 videos together. These videos are very powerful, and I've got to admit that they took a lot of courage, resilience, and vulnerability on our part, and we are really excited about sharing our stories with you. It would be wonderfully helpful to us if you put your reactions in the chat and the questions in the question and answer, gave us a little support, and enjoy the videos. They give a voice to parents and children in families with mental health issues. So let's begin with the parent video, which is about 7 minutes. And if you could run that now, it would be great. We've created a video for parents with mental health and substance use challenges and their providers. We now invite you to explore our stories. Thank you.
So my name is Beth Stark. I am 40 years old. I have a 4.5-year-old son named Philip, and he is wonderful. My mental health issues probably popped up in my late teens and kind of came to a head after I had my son at age 36. It was at that point that I was eventually given a diagnosis of having postpartum depression, bipolar disorder, and I was in the throes of alcoholism. When we found out we were pregnant, I was over the moon. I elated. I had my son, and about 7 weeks after having him, the postpartum kicked in. And at that same point, I started drinking again. And it was during that time that I felt I lost complete control over who I was becoming.
I have 3 children. I have 2 with mental health issues. My substance use and my mental illness affected my parenting style tremendously. So my children had to fend for their own as far as fixing themselves something to eat, washing their own clothes, and taking care of themselves. In the early years, my relationship was very strained with my children. They did not trust me. And it came a time when my daughter became the parent, and she ended up taking care of me once I became very mentally incapacitated at one time.
I tried to keep my illness out of my parenting and not pulling my kids into my illness. That said, it definitely has affected my parenting. I started to suffer from intrusive thoughts. They became so bad that I couldn't interact with the kids at all for a while. So I just totally withdrew.
I'm a single mom, I raised my daughter. She's now 35, and she's really the star of my life. When I got sick, everything kind of fell apart. I lost my home, my doctoral program, and my job. I had to give my child to my parents for 2.5 years. It was a stressful time, but my daughter seemed to do okay because she could hold on to the fact that I was going to see her every weekend. And I'd go through my mental health program, day treatment programs. As time passed, I was able to tell her that I was having a hard time thinking and feeling.
Okay, I'm Ren Whitman. I have a 35-year-old daughter, and I've been in recovery from mental health and substance misuse challenges for over 30 years. Well, at the age of 33, I had just given up nursing my baby daughter, and I began to feel that my office was under electronic surveillance. Within a year, I'd been fired from my job. I'd lost custody of my daughter, and most of my friends had given up calling me, and I was embroiled in a bitter divorce. I felt a tremendous amount of shame and loss, and I began to decompensate.
I didn't know who to tell that I had a problem. I was a brand new mom. Who do you go tell that you think your drinking's scaring you? So I went to a support group. No one was saying I'm drinking too much. My mood feels strange. I don't feel like myself. And so eventually I stopped going. Then the labels came out. Bad mom. You obviously don't love your son. How could you ruin everything like that? So you're feeling already terrible about yourself because you realize you have a lot of problems that you have to sort through. And everybody just thinks you're a bad mom. I know now that I wasn't a bad mom. I was a sick mom that needed help. And there's a big difference between the two.
Stigma was really difficult around the mental health challenges. In my community, a lot is not understood about mental health recovery. And in fact, it got so bad, like after I'd gone through that experience of what other people thought about me, I felt judged, I felt less than. I really felt hopeless. I just thought I'd never have another happy day. So that stigma, it almost took me out. That self-stigma and how other people responded to me. You know, everybody was focusing on what's wrong with me, not what's wrong with me. And I think what's helped, though, is by overcoming that and getting that peer support of being able to connect with other people going through similar stuff, it gave me strength.
So the parents of these children that were her friends were kind of like, you know, who are you? They might not have known what my issues were, but there was that, you know, alienation. I told one of the children's mothers one day that I had some issues. She got so scared. I could see it on her face, and she grabbed her children and brought them in like I was gonna hurt her children, and I would never hurt a child. She just totally didn't understand. That, I felt, was an inability on her part to see the real feelings that we have.
I was told that I couldn't talk to my daughter for 6 weeks while I was inpatient. They felt I needed to focus on my recovery. And I felt a certain amount of stigma not being able to talk to my daughter, and I could have used an advocate to help with communication. Other ways that I felt stigma was a tremendous amount of self-stigma. I was very shameful, and my daughter had a birthday, and it was during her time with her dad. And so I felt I couldn't give her a birthday party because she'd already had one with her dad, and I was the non-custodial parent. But I was attending a group called Mothers Without Custody, which was a community organization. And they convinced me that I could have a birthday party being a non-custodial parent. I was really that shut down. And so my daughter's favorite color was purple, and I threw her a purple birthday party. We had purple balloons, purple cakes, and it's one of the things that she remembers most.
My coworkers would say, oh, she's crazy, or she doesn't have the elevator going all the way up, and little comments that were very stigmatizing, like people with mental illness were not smart or were not normal. It was just a big stigma of being a parent with mental health issues and substance use abuse disorder.
There were a few folks who stopped talking to me. It seemed like it was more a loss of respect. There were folks where it just seemed a little overly sympathetic, like I was less. What I did, though, to try and overcome it was ignore it and to really try and focus on what I needed to do with the kids.
It's difficult to say to him anything in regards to like my substance abuse or my mental health. We will have the conversation with him when he's older, but other than that, there's not too much we've shared yet because he's small.
Little snippets of how I've had to deal with challenges, that it's okay to feel your feelings and that you can deal with them. He also knows that his mother and I are both in addiction, mental health, and trauma recovery. And he knows that we don't drink or use other drugs. So we talk about this stuff. We're open about it. He knows about recovery.
In the beginning, it was very, very hard, a relationship with my children, but today it's a lot better. What helped us was doing family counseling. By doing family counseling, we were able to talk to each other about things that we couldn't talk to each other without a therapist there. We were able to get out a lot of things that was bothering us that we didn't know. For example, I would always yell at my children. I never really talked to them. Well, out of family therapy, I started talking more, treating them more with respect, not swearing as much. So those were successes that I've gotten through the therapy of how to talk to my children. We're getting along so much better today now that we know about our diagnosis, and now that we know how to take care of ourselves, we're able to take care of each other.
The best reward of all of this is I hope another mother sees this, because I know that I needed more moms in my shoes. Life gets so much better, and my son is just walking proof of that. I didn't know that I'd ever get any of that back. I really didn't.
Yeah, so let's take a minute and pause and think about the video and give you a chance to put your reflections and your thoughts in the chat. If you're a parent with a mental health condition, you know, what do you identify with? What might you react to? We're going to get started with the children's video. And Heidi, Ren, and Ziona and Peter in this video are the children of parents in the video. And Gabe is the child of Jackie Martinez, a peer specialist and consultant at COE. Could we get started with the children's video?
My name is Ren, and with the Center of Excellence of Psychosocial and Systemic Research at Massachusetts General Hospital, we've created a video about what it's like to be a child of a parent struggling with mental health or substance use challenges. This video is for families, children, parents, providers, and educators. We welcome you to hear our stories, and we hope this video contributes to reducing stigma and isolation and adds to improving the lives of families struggling with mental health challenges.
My name is Zayana, and I am an outreach coordinator with the Recovery Learning Center in Brockton. I didn't understand that my mom had a drug addiction. I didn't understand that she had a mental health. She didn't know that she had mental health. She just knew she had a substance abuse issue, and it affected our relationship, and it caused a lot of strain on myself and my siblings and our family.
So my name is Heidi, and I am currently in graduate school studying clinical psychology with a focus on neuropsychology. My earliest memories of my mom's condition are probably around the time I was in first grade, so I think around the age of 6. I really didn't understand much of what was going on, but my family referred to my mom as being sick and her needing some time to take care of that sickness.
Or you can just call me Gabe. I am 23 years old. I'm currently working for Thermo Fisher Scientifics as a formulation technician. Some of my earliest memories of understanding my mom's depression or anxiety issues was probably when I was in 7th grade. That's something I understand now, as parents don't like to show their kids when they're stressed out or there's trouble going on. But as a child, you can just notice it. But that's something I never really brought it up to her until it really started being a struggle on me and her.
What I'm doing now is that I'm a psychotherapist, I'm a social worker, and I have a private practice, and I see children and adolescents and young adults. I'm in Western Mass, and I work with lots of folks in the LGBT population. I guess my earliest memory that my mom wasn't doing okay on a weekend morning, and my dad and I taking her to the hospital. And I had no idea what was going on. And that's all I remember. I don't remember like what happened when we got to the hospital. She didn't come home. I don't even really remember going home. I just remember that moment in the car.
So yeah, my name is Peter Burke. I'm a sophomore now at Middlebury College. I'm 19 years old, and I'm studying mathematics here. So that would have been when I was pretty young. So I didn't have a total understanding of it. I remember it definitely being kind of watered down to me almost. Like I knew that he was struggling a little bit, and I knew that I wasn't seeing him as often.
When things were most difficult for my mom, it was terrible for me because she would disappear. She just wasn't there.
Life was kind of like a gray cloud. I really didn't really talk to anyone in general. The anxiety was something I knew to keep that down. I worked hard personally to make sure I got good grades, to, try to make her happy or just work hard around the house.
Is that I was just really, really shut down, and there wasn't really anyone around who could help me emotionally. We saw each other every other weekend and one night a week for dinner, and there always had to be another adult there. And that was hard to develop a relationship.
So I'd lived with my grandparents for a couple of years, and then I moved back in with my mom. And while she was definitely on the road to recovery, she was still dealing with a lot of heavy issues. Like, I think that it was difficult to be a kid and also see your mom in that state. And to also feel some not responsible for her issues, but feel some responsibility for, I know my mom's really upset right now. Like, how can I make her feel better?
I know my mom has told me that there were like other parents in school who didn't want me to like be with their kids outside of school, or I think probably parents who didn't want their kids coming over if it was just my mom around. Another parent in the class who came up to me when I was like 8 and was like, "So I understand your mom's in the hospital." And I was like, "Yeah." So that definitely stands out as a way that people talk about my mom's condition, like without talking about it.
There was a lot of stigma around my mom's addiction growing up, as far as the other kids that noticed that my mom had a drug issue, or going to school and this faculty recognizing that I was unkept or things like that. And the part of the stigma that was hard for me when I was growing up was resources, as far as like mental health support, therapy, and things, asking me questions and probing about my home life. And I was in fear, because we are of color, that I would be taken away from my mom and my home life with her. And so I lied a lot. So the stigma, it caused me to have confusion about getting help and support. It caused me to have strained friendships and relationships and not able to really keep friends.
After I moved back in with my mom, and she was on Social Security, so she was receiving disability benefits because she wasn't working. I think I experienced or felt more stigma around the financial side than I did her mental health condition. I think in some ways I was protected from that, just based on the support of our family and other supports that I had within my own life, like ranging from school to Girl Scouts to friends. I think one thing that was great about my family was that they did talk rather openly about it. Just it wasn't something that was brushed under the rug or anything like that. It was kind of an open topic of conversation. And especially my mom, I think, took the time to really speak with me openly about it in a developmentally appropriate way. But she was really open about her struggles and what she was dealing with.
Well, obviously in my family, it was like a pretty normalized thing to talk about mental health or what was going on. But I also feel fortunate that in the, like where I grew up, it was just, that was something that was talked about in our schools and just in our day-to-day life. But at the same time, I don't think there's anything to be lost from talking about it more openly. I mean, every once in a while I'll hear people say, whether it's make a bad joke or just say something offhand, where I feel like from the kind of background that I'm from, I kind of like cringe a little. I'm like, oh, maybe shouldn't say that.
And my family didn't really talk about it. My mom didn't really talk about it until she was in recovery. I think I developed the belief that like things were supposed to be okay because no one was like saying that they weren't okay, and but like they didn't feel okay. And so then I think I developed a lot of tendencies around like caretaking of others in implicit ways.
The way I was protected by any stigma was not really talking about it. People really never knew about it, so they never really had anything to talk to me about. And it was a double-edged sword because as a kid, I felt alone. But now I'm more open to it because my mom is more open to it, and both having understanding and knowing that we're both in a safe space to talk about it.
It was difficult to understand all of like the complexities of those situations as a 10-year-old. But at the same time, you know, I knew that my mom was trying really hard and that she was working so hard and diligently and was so dedicated towards improving her condition. I really think that she set a high bar for being a selfless, super supportive, like always present. You know, even when she wasn't there with me physically, like I knew that I had the support of my mom. I knew that she was there with me.
My dad eventually moved into a house right around the corner from where my mom lives. And I remember that making things a lot easier, because at that point it made it a lot easier to have a more normal relationship with both my parents because they were both just right there. But I know that he was seeing a group, and I remember one time he came home and they had made chocolate popsicles that night, and I was really excited.
Around my late middle school and early high school life, family therapy did start becoming more of a helping tool. Definitely just having that middle ground and having that person there to articulate my words better, especially as a child, to my parent, and for my parents' words to be articulated better to me as a child.
There was a time when I was growing up when my mom and I had been reunited after me being in the foster care system for over a year. And we had to do family therapy in order for us to get back together as a family unit. And we celebrated that entire week. We went to a couple of her events, conferences for people in recovery, and there were other children there that were my age. I was about 14, 15. And we had a great time. We went shopping for the day. We got our hair and our nails done. And I will always remember that moment. It's hard for me to forget because we had so much fun and we connected so much in our reunification. To this day, I am amazed at how she even did it. She kept a roof over our heads. She, she kept a job. She kept a car. She kept up with her bills.
Well, when my mom came back from inpatient, she started AA. I think AA was amazing for her because there was so much honesty and truth and support there. So I think a big part of things getting better was just people in our family moving out of denial. Part of things getting better was my mom really wanting to make things better and wanting to maintain her recovery and her sobriety so that she could have a relationship with me. We're continuing to get closer. I'm more and more able to welcome her suggestions and ideas and support in ways that I used to push back against. I think that's probably pretty normal for any parent-child relationship, mental illness or not.
The fact that he was still able to stay as involved in my sister and my lives as he was, like, in my mind, there was nothing weird about my relationship with him at the time. And I know from talking to him more recently that there was a period of time where it wasn't super easy for him to have a normal relationship with his kids.
And we spend a lot of time working on our business, working in the community, volunteering, going to our recovery groups. Also, we spend a lot of time doing therapy and self-help. We, engage together.
I was probably in 5th grade and it was probably like the dead of winter. And my mom had the idea to put a picnic together, and we would go to this park where the pond had frozen over, and I brought my ice skates. It was really fun, and it was just a great example of how my mom came up with really creative, really fun activities for us to do that always kind of captured like the magic of life and the possibility that, how fun things could be and how you could, basically make any situation exciting and fun.
I've grown from the experience of having a parent with a mental health challenge by being able to access resources for whatever life may throw at me. I grew up in the recovery system.
What my mom has shown me is human resiliency and people's ability to heal and grow and develop spiritually and emotionally.
I think you don't have to be a perfect parent to parent well. And I think that her ability to be open with me and to communicate at a level that I could understand really helped me to know that she was trying and allowed me to give her that space. I truly understood that this was something my mom was working on about herself.
Parents are human. They make mistakes. They've gone through things. They may be hurting, having trouble healing, having trouble accessing support.
I guess my advice is get the support you need for you and stop worrying about everyone else. And you can't fix your parent, you can't heal your parent, you can't fix anyone else. And it's not your job.
Communicate to parents that even if you're struggling with mental health difficulties, you can still be a great parent, but there are resources out there. There's people who've been through it, and there is a light at the end of the tunnel, and kids can turn out okay.
I've seen some wonderful comments in the chat, and keep them coming. We're going to start now with the panel discussion, and I wanted to talk to Dee. Dee, it's really good to be on a panel with you again. We shared a panel over a year ago, so I'm curious on your thoughts on what came to mind after watching the video.
Yeah, first I just want to thank everyone who's involved with both videos for the courageousness and the open honesty that they had in the videos. It's really amazing, and thank you. A lot of people have been putting that in the chat, which I want to acknowledge as well. So thank you, everyone. As a child of parents with mental health conditions, in some ways I relate more to the child video. And it's super interesting because it shows how different things have been since I grew up, how far we've come and how far we still need to go to really help families and stop that kind of vicious cycle of having mental health conditions almost passed through generations. Because in my family, my mom's dad, my grandfather, suffered from a mental health condition, and my mom had a very disruptive and abusive childhood, which she brought to her parenting. And my dad had mental health struggles as well as addiction issues or challenges. So none of that was talked about when I was a kid. Growing up in the 80s and 90s, my parents, we knew my mom had depression and that was it. So it just shows that the open communication that these families in the videos had had was really important for helping the children understand what was going on a little bit better, having it in an age appropriate way or developmentally appropriate way. And I think the family focused care is really, really important. I think earlier generations really missed out on that, learning how to communicate properly as a family, how to share your emotions, your frustrations, your struggles, and just understanding a little bit of what my mom was going through. My mom struggled her whole life, and I'm not one of those that my mom especially, ended up in recovery. She actually got worse as we got older. She really hit a wall when I went to college and just kind of went downhill from there with her mental health. So I think even looking at older families is important, because you don't stop being a parent when your child turns 18 and you still have an important relationship with that child. But I think these demonstrate, like I said, some of the growth and advancements we've made, and there's definitely more we can do. And I just want to say thank you again.
Yeah, that was very interesting that you commented on the importance of communication and how things may have changed over time. And I also just remember a couple of days ago, you told me you were a little jealous of some of the family members that had good communication. So I think that's indicative of what, we may want for the future. Joshua, I've only met you a couple of days ago. Are you here today?
I certainly am. Hello.
Great. What does the video suggest to you about resilience and challenges that young families face? Good to see you, Joshua.
Likewise, yeah. What the video showed to me is that resilience is very important, but it's not a bottomless well. Resilience is finite, and it takes a community of supports, and it takes that it's really vital to have that, because what happens is, Beth had mentioned, right? I didn't know who to tell. Beth had mentioned, she was told, you are a bad mom. Someone else mentioned, I feel judged, and everyone focused on what was wrong with me and not what was strong with me. But then they mentioned that peer support was what really helped them out. Having that community support is really, really important when it comes to resilience. Having a place to go, having people to speak to, whether that is your family members, your friends, some kind of support, but having that education within the community so we don't have those people who say you're a bad mom, reducing that stigma and making it more like a web, setting up these pillars. These are the things that are really important when it comes to resilience, because people are not like swords. They're not like weapons. You can't just keep pounding them until they become strong enough. We are the exact opposite. We need to be propped up and come together and share in these spaces. And I think in our vulnerability with one another, we then gain resilience. And the way that I've seen this best described was from a quote that I used to kind of pull this all together. And it was a woman named Zandashi L'Oreal Brown had mentioned, "I dream of never being called resilient again in my life. I am exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many."
Yeah, I think that's a wonderful quote to end with. And I think you're, such an important point about how we need community to support us. And that's really important. So thank you very much for that excellent contribution. John, we talked a couple of days ago about what specific supports do you think young families need?
Hello, thank you. My name is John Delic, and I'm a young adult with lived experience in mental health. And I believe that one of the biggest supports for youth and families is peer support. Growing up, I was diagnosed with depression, anxiety, PTSD, and ADHD when I was in 7th grade. And struggling with those as I was growing up led me to often feel like a burden to my family. I would often describe myself to my mom as I'm a sad kid that has a few happy days here and there. And I didn't really know how to deal with it. I didn't really know what was going on inside of myself, and it led to a lot of turmoil. And it led to the point where I was eventually going to commit suicide. By the grace of God, I didn't follow through with it that night. And I was eventually introduced to peer support, where I was able to relate to another individual. And I was able to share how I was feeling, what I was thinking, and I felt understood by my peer supporter. And having that communication led me to better understand myself. And there were times I felt like I couldn't articulate what I was feeling. And I relied upon my peer supporter to explain that to my parents, because my parents were always supportive and they did everything they could to help me. But still, we would bash heads, and I didn't want help, and I didn't want to admit I needed help. And, it led to different arguments. And my peer supporter was able to be the bridge and create that understanding between my parents and myself to today, where I'm a happy kid and, I just have some bad moments here and there. And most importantly, I have a beautiful relationship with both of my parents. And that was all thanks to peer support.
Yeah, that's wonderful, John. And I'm so impressed how peer support really influenced your relationship with your parents and how they ended up changing their attitudes. And I just think that is a wonderful message to take about how families can be supported by peer support. We'll turn next to Heidi. I haven't seen you since last summer, but in the video, you had a tremendously positive acceptance of your mom's and your mom's mental health condition. And I wonder, what do you feel contributed to that?
Yeah, so first of all, thank you to everyone for organizing such a wonderful conference and for inviting me to contribute. Shout out to my mom, who's here today as well. I would say, first of all, development of a really secure attachment with my mom very early on contributed to our wonderful relationship today. I really learned to trust her as a reliable caregiver who consistently met my needs from infancy, which I really believed buffered a lot of the effects of separation and instability and other effects from her mental health condition later on. I always felt like a priority to my mom, no matter what. She took the time to talk to me. She showed me that she respected me enough to talk to me in a real way about what she was going through, and respected me enough to ask me how I was doing, how I was feeling throughout these times. I wasn't kept out of the loop, but rather included and made to feel like an integral part of our family, even though I was only 6 or 7 or 10 years old at the time. And I've always felt a really deep sense of respect for my mom as an individual and autonomous person. She also worked really hard to create stability, structure, and predictability for me in my life through other resources, even though she couldn't provide it herself at the time. So while she was living in her car or in inpatient or in transitional housing, she made sure that I was taken care of. And as some people have referenced today, and as the saying goes, it takes a village to raise a kid. And I had the support of my grandparents, teachers, school, Girl Scouts, basketball, friends. I had so many supports, and I was really fortunate in that way. And I also want to say that I had a lot of pets, which I think sounds silly to some, but I always had pets that I could care for and love. And this was cats, a dog, guinea pig, birds. And these opportunities to care for something beyond myself was therapeutic and really contributed to my own resiliency. It provided opportunities to see beyond myself, to develop empathy and compassion for somebody else on pretty much the simplest of terms. And then finally, I'd say that seeing how much my mom wanted to work at getting better was really impactful. So working at self-improvement, at self-care, how much she really wanted to be the best mom that she could be to me, showed me in like a very real and tangible way that I mattered, that she was serious, and that more important than getting it right, whatever that really meant, she was trying. And I think when kids see that, when they see real effort, when they see the courage to try and the courage to look at yourself and acknowledge the flaws, and try to be better, try to be the best parent that you can be to them, it really opens up a lot of empathy, compassion, and goodwill in the relationship that lasts a lifetime.
Yeah, Heidi, your relationship with your mom is quite a testament. And, you know, the attachment, the care she gave with communication and your ability to adapt, and the importance of everyone trying and moving forward, I just think is a very powerful message. So Ren, it's wonderful to be sharing this forum with my daughter. It's a pleasure. As you know, individuals with mental health challenges and those who identify as LGBTQ often face tremendous stigma. How do you think your identity as an LGBTQ individual has helped you understand and empathize with my experience and mental health challenges? And then a follow-up question is, can you comment on specific supports needed for LGBTQ individuals whose parents have mental health conditions? So I'll leave the floor wide open for you.
Thanks. It is nice to be sharing this space with you and the presentation. And I see a comment about how wonderful it is to see this a day after Mother's Day, and I agree. I think actually the question of understanding stigma from our various perspectives might go the other way, in that I think probably you experienced more stigma in the mid to late 80s as someone with mental health challenges than I did experience stigma as a queer kid in the 90s and early 2000s. And I was in very open, accepting communities and in New England, and you know, I know I had all that going for me. But I think, yes, that's to say you probably experienced more stigma than I did. And I think probably your experience of that stigma led you to worry about the stigma that I might experience, which I then really did not experience so much of. But I do think that we each have our own experiences of being sort of in a marginalized population, and that has contributed to some or a lot of understanding between the two of us. And yeah, I think you saw it in the video too, that I talked about the stigma I experienced as a child of someone with a parent with mental health challenges. So I think that gave me an understanding of what you were experiencing as well, to kind of go through the same stigma for the same reason. And as for supports for children, LGBT children of parents with mental illness, I think the biggest thing I would underscore is having some supportive adult peers, somebody whether that's in the family or outside of the family, but someone who is accepting of and curious about and supportive of that child's queer identity, I think is really important. And ideally that's a parent or a sibling or someone in the family, but if it's not, that can certainly be found outside of the family. And that's something that I think providers and educators can help children and families find.
And did you want to comment a little bit more on LGBTQ families?
Oh, on supports that LGBTQ families need?
Yeah.
Well, I think, yes, you're asking about LGBT parents with mental health challenges. Yeah. I think that's a, you know, like anything, there's sort of two problems to address there, or two issues, right? And what I think we've seen underscored here today is the importance of peer support. And that's exactly what I would say about each of these issues, is that we need peer support around sexual orientation, gender identity, and also around mental health stigma. And so for providers and educators and people supporting families with mental health challenges, I would just continue to say, connect people to community and to peer support, whether it's around mental health or around sexual orientation.
Yeah, well, that's great. A very perceptive response. Okay, I think Jonathan is up next. I'd love to see a picture of Jonathan. So Jonathan, what unique issues arise for fathers with mental health concerns, and what disadvantages and advantages did this create for you in your parenting role?
Hi, and thank you, Anne, for including me on this panel. I'll start with one of the disadvantages, and we've heard it a lot today, and so I will just come back to it. As a father with a serious mental illness, one of the main challenges I confronted was stigma, both in myself and in others. The fathers of the friends of my kids were all succeeding and advancing in their careers. And I was actively sick for 5 years, and then I was in recovery for 5 years, and then and then I was still in recovery. I felt acutely like I had failed. I did not advance in my career as a writer and a reporter. I had let my kids down. From other parents, I often felt like I just wasn't taken as seriously. And so, you know, especially, you know, for you know, off-island Little League trips, socializing was difficult. And part of that was me. Fortunately, intellectually, I knew that stigma was not the important thing about parenting. And so I really just put one foot in front of the other, and I attended birthday parties, and I hosted play dates, and I gave my kids a bath and brushed their teeth and read to them the bedtime story. I ignored the judgment that I felt in myself and in others. Disadvantages, when I first saw the question, I was like, are you kidding me? Advantages? What advantages could there possibly be? But then I thought about it, I thought ironically there are. And one of those advantages is adversity. And my kids have been able to see me cope with and overcome adversity. And I believe that has taught them that they can do the same. And the adversity I have felt, I think, has given me insight into other people. Life is hard for some people. It's not always fair, whether it's a disability or another disadvantage. Everybody should be treated with dignity and respect. And that's another lesson that I've tried to pass on to my kids.
And we talked a little bit the other day which I found interesting about you being assigned gender roles based on being a father with a mental health condition. Could you just comment on that a little?
So, yeah, and I guess what I was really getting at there was the Off Island Little League trips. I did Peter's Little League, and Karen, my ex-wife, did our daughter's dance. And for example, it was just hard for me sometimes, and some of it was also just directly related to symptoms of my mental health condition, anxiety. For example, and it gets back to the idea of socializing with all the other fathers, but we had one trip where we were, it was like a 3-day trip, and we were all, sleeping together in this one big room with bunk beds, and it just caused a lot of anxiety for me. And in my role as a father, getting back to the, having succeeded in my profession, all of the other fathers, whatever their chosen profession was, they were advancing, they were doing well, they were supporting their family. And in my case, I was coping with my illness and I was being supported by my family. And that was kind of difficult for me.
I can understand that. I also actually got assigned, because of my mental health issues, the evening activities, because mental health medications kind of put me under in the morning. And I missed out on a lot of conversations that go on in the schoolyard when you deliver your child. So yeah. I can understand that. Yeah. I want to bring Heidi and Ren back if we could have them. Thank you very much, Peter, for that insightful part on fathers. Heidi and Ren, as future and current mental health providers, can you comment on how children develop resiliency in the face of adversity? I'll let Heidi go first and followed up by Ren.
Sure. So I think there were some great talks today that touched on this already. So I'm going to call back to some of what Dr. Holt presented earlier, because I think the most important takeaway about resiliency is that it can be learned. Some people are, of course, just naturally more resilient than others, but I think really all kids can learn skills to become more resilient. There are a lot of different components related to resiliency as we learned today, but the ones that I want to touch on are really the ones that have been the most important in my own experience. So I'd say the first thing is self-care, teaching and encouraging pro-health behaviors for physical health, but also mental health early on really sets kids up with a toolbox of coping strategies to help manage their own emotions. So my mom would always tell me, your body is your temple, and she'd encourage me to treat myself with respect, which included things like eating healthy food, getting enough sleep, as well as strategies for dealing with stress and listening to what my mind and my body needed. I think one of the greatest gifts that my mom has given me has been how to stay optimistic and hopeful in times of adversity. So she taught me, often through her own example, how to experience difficulty and failure as temporary, as a part of a broader journey. So she always encouraged a sense of curiosity, a willingness to take appropriate risks, and the courage to try new things. So even if they didn't work out as I really expected that they would, I learned so much from just trying. And it really opened up my world of possibilities because of that. But I think the most important component of resiliency is developing strong, supportive, reliable relationships. So ideally, this would be with a primary caregiver, because as we know, that attachment style, or how somebody really relates to others, is formed early on in life. And once it's established, it really influences how we relate to others for the rest of our lives, including how we parent our own children. And research has shown that the secure attachment style, which is characterized by trust and believing in the caregiver's consistent responsiveness towards the child's needs, forms the foundation for secure and trusting future relationships. So even though I was separated from my mom, for about 2.5 years. She had really established the foundation for basically an unbreakable bond and my belief in her as the most trusted person in my life. So that by the time I was 6 or 7, our relationship was so solid that I could withstand these hiccups and challenges that resulted from her mental health condition and ultimately have our bond that was unshaken because of that. I know that I was super lucky to have that relationship with my mom, but research really shows that secure, supportive relationships with secondary or support caregivers like teachers or community leaders, friends, parents, extended family, all support resiliency as well. So in my own experience, I was lucky enough to have many of these relationships with people in my life, like my grandparents, parents of friends, along with other community supports. And the relationships and connections that we establish with others really kind of serve as the bedrock for psychological well-being, and being able to develop these affirming, supportive relationships will really help develop resiliency throughout the lifespan.
Well, you already sound like a full-blown clinician, a practitioner. That was a great response. I wonder if everyone can see me, because I can't see them. Can people still see me?
I can still see you.
Okay, great. Ren, do you want to add anything to that?
Yes, I also still see you.
Good.
I think one thing I would add, which Heidi touched on, but just underscore, is the importance of children having experiences of repeated success to build confidence. And part of achieving success is also experiencing failure, which Heidi talked about, having opportunities for that as well. But knowing that you can experience failure and try again, and then learn self-reliance and the ability to trust yourself. So that could look like many things, you know. I think starting with what the child is interested in. So it could be art, music, sports, Girl Scouts, camp, any of those community supports, I think, are just vital for developing self-reliance and the ability to withstand failure in order to move on to success. And I think that it can create a sense of stability within the child, even if their home environment is chaotic, when they start to learn over and over again that they can rely on themselves and that they can achieve what it is that they're looking for, or that they can get to where they want to go. That is a huge buffer to what might be going on in the home or with a parent with mental health or substance use challenges. And, you know, for me, I would say I had a lot of opportunities for that, a lot of opportunities to do things outside the house, with other adults and other peers. I was at camp. I was very involved in sports. I had a lot of people, a lot of adult mentors who helped me learn those lessons. And the other thing, I definitely would agree with Heidi about the supportive, reliable relationships being important to resiliency. Probably, as you said, Heidi, the number 1 thing to build resiliency. And what we know from research is it only takes one adult, one reliable, trusting relationship. So that's pretty important takeaway. And I think I know that person can be inside the family or outside of the family, right? So as Heidi said, we hope it comes from a consistent, reliable caregiver, but if that's not available, mental health providers and teachers can help children connect with other adults who can provide stable, reliable relationships. You know, and in my experience, I think I had that outside of the family and maybe as a younger kid. And then as I got older, I had a chance to develop that with my parents as you both became more available.
Well, thank you very much. That's really important perspectives on what will build resiliency. I'm afraid we're out of time for the panel discussion, but we do have some time for Corey to ask some questions from the audience to the panelists. So Corey, do you want to take over?
I would love to. And please, please do put more questions in the chat. I see some people raising their hands. We don't have that ability to call on you. So please enter your questions in the chat. But there is one question here, and I'm going to open it up to everyone because I'm not sure who will have the best answer for this. But so panelists, There's a thank you for your sharing. And the question is, what would you recommend to a young person when parents are no longer around to work through the loss and grief?
I can start with that. I think that's obviously a really challenging situation. And my heart goes out to that young person and other young people in similar situations. My answer might be biased, but I would recommend therapy. And it depends on the age and the interests of the child, but therapy doesn't have to be sitting and talking in an office. It can be art, it can be movement, it can be with animals, but something that can allow a child to process grief and loss of their parents in whatever way is going to work for them that's developmentally appropriate. And again, I guess I would highlight some peer support. That's therapeutic too. So I'd start there. I'm curious to hear what others have to say.
Yeah, this is Dee. My parents both passed away at young ages, and my youngest brother was 27 when they passed away, and he was still living at home with them. So for him, it wasn't just losing his parents, it was losing his home at the same time. So I think there needs to be thoughts about what the young person or child needs other than just therapy, like what social supports, what if they've never looked for an apartment before, they might need help finding an apartment. How do you go through the whole funeral arrangements and everything like that. So there's a lot of supports that a young person needs just outside of grief counseling and therapy. I think that could be helpful so they don't just feel so alone. How you access those, I don't know. That could be a real challenge.
Yeah, we're thinking a lot about access, I think, today. I had a question for the panel, and whoever wants to answer this one. We're talking a lot about stigma and, the stigmatized views of the public. We didn't talk a ton about other family members and extended family. And I'm wondering what role you think extended family members can play and how to best involve them. Because I think one of the things that we don't tend to do is we don't tend to actually include extended family members in family therapy. And just wanted to get people's thoughts on whether they had experiences that went well or experiences that didn't go well with the extended family, having a better understanding and opening up communication.
To add my thoughts on that, I think something that is really important. One, you should always try and have what I'll call chosen people in those kinds of meetings, right? That extended family component is a natural support, something that you really want to have around. Having therapists and clinicians and even counselors, all of those things are of vital importance, like I've mentioned before. But having those natural supports, like extended family who are going to be around when, say, your therapist isn't in office or has another appointment or what have you, is really important. And I think to add on to that, it's not just extended family who you might want to choose, but maybe there are people in your life that other family members really appreciate and enjoy, but are not conducive to your own recovery and your own health. Maybe you don't want them to be in the family meetings. So it goes both ways, who you want in there and who you don't want in there, and for extended family.
Yeah, I mean, even within my immediate family, it took my dad until he was in his 50s before he acknowledged that mental health conditions are real and it's not just a manipulation tactic to control other people. So he could have used, it's not just the extended family that sometimes really needs that, it's the internal, close family. And I think it really depends on how comfortable the people involved are with their extended family. You know, if you have people who are supportive and who you already talk to, those may be folks you're interested in having brought in. But if your family, like Joshua was saying, if there's people who actually are detrimental to your mental health and your family, then you definitely have to have boundaries set up to keep them out of it and make sure they aren't included.
I would say, Corey, just along the lines of what the other two folks have just said, the more support, the better. You know, if I look at it from my kids' perspective, their grandparents were so important to their growing up, especially when I wasn't able to be there. They kind of filled in for me. And then just, you know, as a person with a mental illness, to have an aunt or uncle who kind of understands what you're going through and is supportive of what you're going through, it makes you feel good. It helps.
I would say just personally, I benefited so much from extended family support. Like I mentioned, my grandparents, my mom's sister was, you know, I'd spend summers with her sometimes, and our family, my relationship with our family, I think was very different than my mom's relationship with our family. And so I think sometimes there can be some difficulties within family relationships, of course, but as the child in the situation, like having those reliable relationships and having familial support was so, I think, integral to my resiliency, even if my mom was struggling perhaps with those same relationships herself.
Yeah, Heidi, I wish that I had had that more growing up, because I agree, it's really important for the child to feel like there's people that they can talk to and connect with and supported, even when their parents don't, or their parents are really in a tough place.
I think I would just add that clinicians and peers and teachers can work and probably do better around not assuming that the support is the immediate family, and simply asking questions, right? Who would you like to have here? Who is the most supportive to you? And it doesn't even have to be a blood relation. Maybe it's a friend, maybe it's a roommate, and just remembering to keep an open mind about that.
So I am a product of having grown up in a family with mental health conditions, as well as different factors that also contributed to my developing a mental health condition. Mine started very young. My mom would joke that I started exhibiting symptoms when I was like 5 or 6, but they got much worse when I was 11. And I see in all my siblings that we all have different levels of mental health conditions. Some are willing to acknowledge it more than others. Some are more willing to get help than others. I know that one of my siblings who has a daughter has worked really, really hard with a therapist, family therapy, in order to not continue that behavior, in order to kind of stop that boulder falling down the hill, if you want to call it. So I think it's hard. You have to protect yourself, keep an eye on yourself. And it looks like John came off, so I'm gonna let him talk.
Dee, I apologize. I did not want to cut you off. The only thing that I would like to add is that it may or may not happen. You know, there's really no telling what's going to happen or what the future holds. But I can tell you and I can assure you, this is something that you can get through. Recovery is possible. Better days lie ahead. And if you are afflicted by mental illness, it's not a death sentence. You're not broken. There's nothing wrong with you. It makes you unique and it makes you who you are. And from my own lived experience, my own personal struggles in the past have been my strengths that I've been able to give and to be of service to others. And it's just a matter of putting one foot in front of the other each day. Thank you.
Thank you so much. Right, of course, that is the truth, right? There are plenty of people who have mental health conditions who don't have a family member with a mental health condition. And then there are people who have mental health conditions who do have children with mental health conditions. And, you know, I think part of the theme of today is talking quite a bit too about environment and resilience and inner things that all interact to determine. So there are no guarantees in life. Everyone gets thrown curveballs, and we so often think that mental health is a guarantee, and that's not right for any of us. And mental health can be restored. It's not something that's broken forever. Wonderful. I'm not seeing any more questions in the chat. Did any of the panelists have any final comments that they wanted to add?
There is one more question in the chat from Victor. You see that?
Oh, sorry, I didn't scroll down. Thanks, Victor. Okay. Victor's question is, I'm very concerned about kids and youth who have given up and either think about suicide as a way out or who actually take their own lives. The ultimate goal of therapy is to instill hope. I'd appreciate if you could share with us, how did you go from hopelessness to hopefulness, or what helped you be hopeful?
So having actually a suicide attempt myself, I remember it just felt like there was no way out. I didn't think things were going to get better, and that there was nothing I could possibly do to improve upon my current situation, because I had been taking the necessary steps that I believed would lead to, you know, a better situation for myself. What was the big turning factor for me was peer support, because it put someone with a similar lived experience as myself right in front of me. It was like I was seeing an older version of myself, someone who had gone through different struggles and similar struggles as myself, wanted to take their own life, and they were able to turn it around and live a happy, helpful life. And seeing that it could be done by someone who was very similar to myself is what gave me the hope that I could make it out myself too.
Thank you so much. I'm going to just thank everyone and turn it over to Anne for some concluding comments, and then we will move on to our wrap up.
I just want to thank all the panelists for their courage and straightforwardness. It seems like some of the themes that have come out of it is the importance of peer support, good communication at all times in the family. Also finding supports outside the family or supporters if they're not naturally occurring in the family are some of the themes that have come out of this seminar and these videos. And I just want to tell people that if you have more questions, you can email us. We'll be sending you a resource list after the conference, and we'll also be sending you the child video with the survey, because we'd like feedback on what you thought about it, how it might be improved. We're still have one more edit left on the children's video, and your feedback would be very important to us. And it's been wonderful to share this afternoon with you all. And I'll turn it back to Corey and Marianne, who will close out the conference.
Thank you so much, Anne. It's been a wonderful day. I am so grateful, and I thought maybe we could actually comment on each talk or on our overarching themes that we each saw. If that would be acceptable to you, Marianne. What do you think?
Sure. Yeah, absolutely. I was actually spending some time during this panel, kind of thinking about sort of knowing that we had this wrap up and finding myself just humbled by the power of this last panel, the videos, the discussion, and the work that we do as research centers. We try to use the tools of research to shed light on sort of information that can help improve the lives of people who struggle with mental health conditions, their families, our communities. And there's nothing more powerful than this kind of a panel, and that both of our centers really emphasize doing work in partnership with people with lived experience and other stakeholders as well. It just it brings that strategy to really into focus on how important that is, and how rich really the work that both of our centers do, which is both to do things like Kathy presenting a lot of numbers and showing how that can lead to really incredibly important policy changes in the way that emergency departments try to improve, not having certainly young people sitting in emergency rooms for any longer than they have to, and trying to get them into a good and better situation for them. So that's a line of research, and then using research to develop incredibly important interventions to prevent the development of more serious mental health conditions. That is also such a hugely valued line of research, and that both of our centers engage in trying to develop really effective and useful interventions that help people. And to doing qualitative research like Kathryn was sharing, that helps to shine a light on the experiences of people who are struggling, with their mental health, both, just putting their experience of mental health into the context of an entire life trajectory from being a high schooler to being a young adult, and really showing in an incredibly rich way the patterns that contribute towards those life pathways, and looking for ways in which we can, if we understand that, how we can essentially support them better to have the best life that they can. And then this incredible panel at the end. In many ways, I end up feeling really proud that DMH has chosen to fund our centers to do this kind of research, and B, that we have these centers to do this kind of work, to try to be helpful and useful to the Commonwealth, and trying to highlight the experiences and voices of people who are living with mental health conditions and their families and communities around them, and try to use our tools to help make that better. I don't think there was any any better example to think about, how much more work we had to do, but also what the progress that we've been able to make than this final panel. So I feel both humbled and proud at the same time, and grateful that we've had this opportunity here today to be here and to try to share the work and to learn from one another.
Beautifully said. And what really comes through for me is the 360-degree look at these different issues. And I too was so grateful to have the commissioner kick us off with such encouraging comments, and also really a vision of a future that improves the public health system and responds to problems. And of course, Dr. Sanders' presentation, that was so data rich, and the transparency and courage really in that presentation of sharing those numbers, of sharing a problem with stakeholders, and showing the awareness of a problem and a sensitivity to the human being who is in the ER, and thinking about that experience. So I was incredibly grateful of that for that presentation, and also for the thoughtfulness around looking at social determinants of health, thinking about how that breaks down by race, observing that the rates were longer for Black youth in the ED, and the importance of keeping that lens was really incredibly important, and also I think certainly it's been Dr. Sanders's mission, and we know how hard she's worked on resolving these problems, and hearing that things are being done about it, and that at the most basic level, more beds are being created is a very important thing. And then the way that just dovetails so beautifully with Dr. Holt's presentation, thinking about the challenges of COVID, but the challenges for youth and families that predated COVID, and what is happening in our society that we're seeing this increase in suicidality, as some of the attendees have pointed out, among youth, and trying to think about what can we do about this, how can we work on these upstream factors and identify perhaps some of the things that the panel is talking about here in terms of community. I love from the video, Scott Francis has the quote of feeling your feelings, not engaging in emotional avoidance, and being open and communicating about mental health, how important that is. So I thought that everything just fed into each other so beautifully, and Dr. Sabella's work, and really hearing the voices of people who are being served by community and public psychiatry, perhaps the Department of Mental Health, and what do they need, and what are they saying, and how can they be better parents, and what will it take for us to think about kids not being afraid to ask for help and not being afraid to be a burden when they know that they might be someone who might be needing that kind of help. So I love the demystification that I think is happening through this kind of conversation and openness. And I hope that we are being true to our mission of including the voices of various stakeholders and trying to do good work that helps people. And all of you who've attended today are part of that. We couldn't do this without you. We need your voices, we need your input, and we are very grateful to have this opportunity to showcase what we do over the year. So until next year, we will have our next conference. I just, incredible privilege to do this work, and we do it, I think, with a lot of gratitude and with humility. So I can't thank everyone by name, but I would love to. I think what we really do want to do is we want to make sure we give you time to complete those evaluations right after the program. Again, enormous thanks to everyone. Marianne, if you have a concluding word or two, please take it. It's hard with this Zoom format.
Yes, no, I'm just, we're so glad that so many people were able to attend today. Hopefully folks found it stimulating and motivating to continue with the work or the experiences that we do or have, and that the evaluations are incredibly important to helping us think about next year as well. We very much want to be responsive to what people would like to hear about, what is out there in research and lived experience around what is the topic for next year. So I'll plant that seed as a final thought for today and say thank you.
Thank you. Goodbye, everyone.